Okay, good evening all. Good evening all. If I could please have your attention, thank you very much. Okay, welcome all to this evening's Health and Adult Social Care Policy Accountability Committee. Welcome to colleagues here this evening in person and also guests joining us as well remotely. Thank you very much. My name is Councillor Natalia Perez. I'm the chair of the Health and Adult Social Care Policy Accountability Committee. Before we start, I have a few housekeeping points. This meeting is being live streamed to the Council's YouTube channel. By participating, you are consenting to being recorded. Please can officers and guests introduce themselves when they first address the committee. Also, please keep your microphones muted unless you are speaking. If the fire alarm sounds, please leave the meeting in an orderly fashion by the nearest exit, which is in the lift lobby and down the stairs. Officers will direct you to the assembly point in Shorelands Road. Let's move on into agenda item number 1, apologies for absence. And we have apologies from Councillor Anne Rosenberg and also Victoria Brignall. Agenda item number 2. Okay. Yes, Councillor Rebecca Harvey has also sent her apologies. Agenda item number 2, declarations of interest. Do members have any declarations of interest? No. Okay. Thank you very much. I would also like to give a warm welcome to Councillor Emma for joining us for the first time this evening. Welcome. Thank you. Great. Joining us at the committee. Thank you very much. Okay, agenda item number 3, minutes. Do members agree the minutes of the meeting held on the 19th of July as an accurate record? Yeah, yes. Yes, great. Agree. Thank you very much. Then,
point of clarification, on the item number, just let me find the number 4, about the impact of the delayed rebuilding of St Mary's, Charing Cross and Hammersmith Hospital. Has there been any progress on that as far as you're aware? I know you've been talking to Tim Orchard. Is there any progress, or is it still the case that they don't have the money to build it for 2030?
as far as I know, they still don't have the money. I think they're putting together the business case for Charing Cross and Hammersmith. That's as far as I know, they still don't have.
And not, no, they don't have it. Thank you.
You're welcome. Yes, Jim.
Thanks, Chair. But 2 things in the minutes. One actually is in reference to what Councillor Coleman raised just now. When Dr. Claber, now Professor Claber actually, when he spoke to us last, he was extraordinarily thorough about the building of both St Mary's and Charing Cross. Since then, I've noticed in the medical press that there is speculation that rather than have bespoke hospitals to match the needs of each community, there may be a standard model rolled out for the country. If that happens to be the case, could we ask that Professor Claber or Professor Orchard come and discuss with us what the implications are for our community? Because lots of time and lots of money and lots of effort have gone into building, rebuilding St Mary's in requirements of the local community. So if there's a change, we need to talk about it.
Absolutely. I think that's a very, very relevant and important suggestion. We do have at the end of tonight's meeting suggestions for the work program. So perhaps we can include these as a suggestion for our next meetings.
Could I, just to be greedy, raise a second point? It's on a different part of the agenda. It's on the palliative care, which we've discussed quite thoroughly here a number of times. The engagements on the options are due to open on Monday. We were promised that the options paper would go out to all H&F people who were interested last Friday, but we got an email this evening saying that the ICB will not sign them off until Friday evening of this week, which means there's no time for people to circulate, to read properly before the Monday meeting. I think we should take a view. This is deplorable. It's happening so often. It's become a modus operandi by the local ICS that people go into a meeting faced with slides, not having had time to read them, or in some cases, like myself, at the moment, I'm visually challenged, not able to read them at all. I think this council sends out everything in advance, and we should ask the ICB to do the courtesy of doing something similar.
It's noted. Thank you very much. I think we definitely can request this. Yes, Mary.
Can I just follow that up? On behalf of Hafson, I have sent a message tonight asking that there be another Hammersmith and Fulham engagement meeting, because ours is the first one, which means Hammersmith and Fulham residents are going to be the most disadvantaged, because that meeting is supposed to be next Monday. I think it would be very useful if the scrutiny committee could itself also ask that another engagement meeting be organised for Hammersmith and Fulham residents, so that there is time for residents to actually read the papers. If they only come out on Friday or later this week, there's no time to alert people and to have them look at those papers and to fix their diaries to be at the meeting on Monday. Thank you.
Thank you very much, Meryl. The members of the would agree to that request? Yes. Good. Yeah. Okay. Thank you very much. Yes, Linda.
Chair, I can take an action as well. If scrutiny wants to write to the ICB regarding that, but also I'll email Rob Hurd, the chief exec of the ICB, tomorrow to say we're not happy about it and request that it's delayed.
Thank you very much, Linda, for agreeing those actions. That's appreciated. Okay. Thank you for those points of clarification and those suggestions as well. Made. Okay, I think we're ready then to move on to the next agenda item number 4, Safeguarding Adults Board Annual Report 2022-2023. So this item presents the Safeguarding Adults Board Annual Report, and we asked to review it and comment. So this evening, we have with us presenting Mike Howard, Safeguarding Adults Board Chair, who's joining us remotely. Good evening, Mike.
Good evening, Chair.
And we also have with us Siri? Carrie. Okay, we apologize for that. Carrie Gordon, thank you very much for joining us this evening. We should also note, please, that in addition to the papers that we have, the agenda that we have, a video was circulated for members to watch prior to this evening's meeting, summarizing learnings from the Allison review. Great, thank you very much. Okay, so who would like to start, please?
I'll start if I may, Chair. Thank you very much. My name's Mike Howard, and I chair the Safeguarding Adults Board for the Borough of Hammersmith and Fulham. And I'm here tonight with colleagues to present our annual report, which was written and signed off by the board at the end of June. You'll notice it's deliberately short because in the past I've presented annual reports, and one of the things that people like yourselves want is clarity and brevity. So hopefully we've achieved both of those. I'll just talk through the report briefly and then perhaps concentrate on our impact and our achievements, which is probably what you want to hear about. So the report talks a bit about the role of Safeguarding Adults, what we are there to do. We are a statutory board established under the Care Act of 2014. And in a nutshell, it's the first line on page 3, who are we? It's about protecting someone's right to live in safety, free from abuse and neglect. And there's a very wide definition of safety, abuse and neglect. It's not just physical harm. It can be psychological harm. It can be abuse in its widest form, emotional, sexual, etc. And we're also about preventing the abuse of adults who might be unable to protect themselves because of their disability or care needs. So as you can see, Chair, it's a very wide definition. And it's very important to stress that it is not just the responsibility of adult social care within the local authority. It's everybody's responsibility. And you can see that on the list of agencies that participate in the work of the board. And I won't read them out, but there are a lot there. And I'm pleased to say, Chair, that only in the last few weeks, we've added 3 more agencies from the third sector: advocacy, Turning Point, and Graceful Care. And if you did manage to see the video before, you'll see that Kenny Dixon contributed to the video, and we're very grateful for Kenny's participation, and he has kindly agreed to join the board. So the purpose of the board is to work in collaboration and to reduce the risk of harm to adults in the borough. So the report then goes on to talk about the local picture, and then talks about what we've been working on. And I would just like to stress the multi-agency aspect of the board. As I said, many people associate safeguarding adults boards with local authorities. And whilst it's fair to say that the local authority are probably the most important players in it, they are by no means the only players. And we couldn't do it without the contribution of other key partners. And their contribution is really best exemplified by their work in the 3 subcommittees that really drive the work of the board. So you've got Helena Peros from the ICB, who co-chairs the Quality and Practice subgroup. Her fellow co-chair, there is a vacancy, but we're hoping to recruit somebody soon. The Case Review Group, which looks at all those cases of the most serious harm, and 2 of which have ended up in safeguarding adult reviews. The Allison one, which you've already mentioned, Chair, and there's another one which will be completed very soon. That's been chaired since its inception by Parminder Sahota, who is the Director of Safeguarding for West London Health, and up until her retirement by Lisa Redfern. And now I'm pleased to say that Linda has taken on Lisa's role. And then we have the high risk panel, which looks at cases which are very intractable, where single agencies feel that they can't actually satisfactorily resolve the case to the satisfaction of the person concerned, and that's very important. And that's chaired by the borough's Chief Fire Officer, Lloyd Palmer, and excuse me, sorry, I've got my chairs wrong. Sorry, Linda. The Case Review Group is chaired by Parminder and our new Detective Chief Inspector, Mark Staples, and Linda chairs the Case Review Group. Sorry, Linda chairs the High Risk Panel with Lloyd. So apologies there. And the report discusses and outlines the work of these 3 subgroups. So what is always what I'm asked for as a chair of both safeguarding adults and children. And we've spent a lot of time in the report trying to answer that question in terms of the very tragic death of Alison. Alison was the latest, I'm sad to say, in a number of fire deaths which the borough has had over the last 3 or 4 years. And work had been put in place to try and take some remedial action to prevent them. But we decided that with the case of Alison, we needed to instigate a safeguarding adult review, which was written by a recently retired fire commander who did a lot of work in Sutton. You'll remember the tragedy of the 2 sets of twin boys who died a couple of years ago, and also did a lot of work in Lewisham. And Martin wrote the review. It's interesting that fire deaths, and sad to say that we've had recently in Hounslow, only a few days ago, another tragic fire death which took a family, has certainly been on the increase in London. So Martin's work has helped inform the work of elsewhere. So you'll see what we've done in response to that tragedy. The video is a really innovative way of getting the message across. Pleased to say that that's been shared with partners both across and outside of London. It's attracted the interest of colleagues in the northwest of England, as well as the fire service nationally through their national lead in Essex. There's an awful lot of information there about how individual agencies have responded to the death of Alison and what they've put in place. And to help reinforce that learning, we've written what they call a 7-minute briefing, which is designed to use for agencies to use to pose some questions to staff about the lessons from Alison. And then on the reverse of it, we've also tried to give some guidance to managers, team leaders, etc., when they're using these 7-minute briefings to try and help them to frame the discussions. There's also a leaflet which has been circulated, and there's a lot of work that continues to go on to try and make sure that people feel safe in their homes. And this is where people like Lloyd and his colleagues have done a tremendous amount of work in raising the risk to people of fire and what can be done to reduce and mitigate that risk. One of the aspects of the tragedy of Alison and others is self-neglect. And that's an area of work that we continue to look at. The high-risk panel, which I mentioned earlier, has cases of self-neglect. The case of Alison it featured, and in the SAR, which will be concluded shortly, which involves an ex-soldier called Brian, that will also be looking at self-neglect. So that really is what we've done briefly in terms of the so what. You'll see on the annual report, we've got a strategy of what comes next. This was devised back in the summer, one of our first face-to-face meetings since the COVID pandemic. And I'm very pleased to say it was well attended by most of the senior representatives of the agencies that sit on the board, and they've devised this strategy which we are working on through this current year. We're very keen to involve the third sector, the voluntary sector, more, hence the recruitment and the 3 agencies I mentioned earlier who have joined us. We publish occasional newsletters, roughly one every 4 to 5, 6 weeks, which talks about safeguarding adults in Hammersmith and Fulham, and tries to bring the work of the board to the widest possible audience. We highlight issues such as fire safety, discriminatory abuse, domestic abuse and older adults, the work of the Drug and Alcohol and Wellbeing Service. That was in the first edition. In the second edition, we again keep talking about the fire message, this time from the London Fire Brigade. We're looking at use of legal powers and multi-agency responses. And in the third newsletter, which has just gone out, we've been talking about Safeguarding Adults Week in London, which starts next week, which is a London-wide event. How to report missing persons to the police, sharing best practice, because I think it's very important, Chair, to stress that Safeguarding Adult reviews, people think it all the time looks at things that don't work, but it also looks at things that do work and how we can make sure that this best practice is put to the widest possible audience. So it's not just looking at things that don't work. So that really is a sort of whistle-stop tour through the annual report and the work of the Safeguarding Adults Board over the last, since the summer of last year. I'll stop there, Chair, if you've got any questions, or if Linda or Kerry or I see Dr. Lang, I think, is in the audience, want to add anything, I'll pass to them. But for the time being, thank you very much.
Thank you very much, Mike, for the comprehensive report. Thank you very much, Kerry, as well, for the written report. It's appreciated the summary that has been provided in terms of that multi-agency working and the importance of the recommendations following the lessons review, and how you're engaging as well in terms of embedding some of these recommendations going forward. So thank you so much. I wanted to invite members of the panel. Okay, I've got Keith and then I've got Jim. Look.
Yeah, hi. In the work I do, I've come across many clients who are living in substandard private rented accommodation, where landlords are not inclined to carry out repairs. I've had to refer several landlords to the Environment Public Health Department. Some of the repairs involve water and electricity very close together. And I'm just wondering how the Safeguarding Board looks at this. Do you work in coordination with the housing department? Is there any way of licensing landlords? Is there any way of getting them? I mean, even then when they serve notices, it takes them ages to do it. They're dragging their feet. And quite frankly, there are risks in these properties.
Well, we did discuss this, if you remember, probably about a year ago, Councillor, the sad death of the little boy, Awab Ishak, in Rochdale, which achieved national prominence because the coroner, this was in Rochdale, where Awab's parents were begging the housing providers to provide suitable accommodation because there was mould. And the coroner took the very unusual step of writing a letter, a formal request to Michael Gove and Stephen Barclay, saying, well, what are you going to do about it? And demanding a response. I think it's a Regulation 29, but forgive me if that's wrong. And we discussed that, and we had input from colleagues from housing. And they provided us an update with what they were doing to look at housing repairs. Now that work is ongoing. So I can't give you a definitive answer, but I have been discussing safeguarding from both adults and children with Richard Shui, and perhaps Linda or Nikki are in a better position to tell you from a local authority perspective, but that's what the work of the board has been doing, looking at some of the issues that you raised, Councillor, following the tragedy of the death of the little boy Awab Ishak. And I noticed that even on the London news, I think in the last 2 or 3 days, some of the issues that you've highlighted have been highlighted elsewhere in London with people living in completely unsanitary, if that's the right word, conditions. So we don't look at things individually, we look at things across the board. But certainly we have raised it and we have had a response, and it's a subject which the board has looked at, but I can't give you a definitive answer as to what housing in Hammersmith and Fulham will be doing. So maybe, as I say, colleagues from the local authority would be better positioned to answer that than myself.
Thank you. Linda, do you want to answer that question?
Just in response to that question. So Richard Shui and Roy Morgan both sit on the Safeguarding Adults Board as representatives. People will know, and people around the table, we do have a whole improvement programme for our council housing stock and the work we're doing there, and damp and mould is high on that agenda. There's also work happening in the private sector landlords as well, and they are obviously monitored, and some of them licensed under houses of multiple occupation, some have private rented agreement. So there's some further work happening in that area. It may well be perhaps we take, Mike, into consideration an update back to the Safeguarding Adults Board to ask our housing providers where they're at with that piece of work.
Yeah.
Thank you very much.
I mean, in fairness, Councillor, we did have a comprehensive update going back a few months ago, looking at the work that they were doing, as Linda described. But I think, you know, yours is a timely prompt to ask either Richard or Roy to give us an update at our next meeting, which is only in a month's time.
So just
so what I'm suggesting there to Mike is that we can put it on the agenda for the Safeguarding Adults Board in terms of private sector and how our own local authority housing doing on housing repairs performance, but specifically around damp and mould.
Yeah, okay.
Dr. Lang, you wish to?
Thanks, Councillor Paris. So there's also, just to supplement what Linda has said, there's an easy read guide for the NHS social care and probation services that we created in February 2022, actually, following the intervention of Councillor Coleman. It's super easy to use. As Linda said, the council housing stock is undergoing huge work, but sometimes the private rented sector can be difficult. But the new housing safety team is led by an assistant director called Ed Shaler. They also have a dedicated email. So any issues with private sector housing or also social landlords like housing associations, it's all in the easy read guide. So I myself am finding it much easier now to enable enforcement action, as you say, Keith. When we're having a family in distress or something like that, it goes to the generic email and they pick it up right away and they can do their environmental health checks. So yeah, and thanks to Mike as well, it's gone to Safeguarding Adults Board and Local Safeguarding Children Board. So it's been helpful, but still we need to have more to do.
Thank you, Dr. Lang. And now I have Jim, Emma, and then I'm going to invite you, Councillor Lloyd Harris. I'm just following the order.
Okay, I thought, to me, that seemed a very comprehensive report with the really dreadful story of Alison. One thing occurred to me, looking towards the end of the report about the multi-agency list, which is very long. It's approximately 30 agencies there. It seems very comprehensive. One thing did occur to me, when you work out somebody suffering from self-neglect, or perhaps an isolated, frail, elderly person, or somebody who's got borderline dementia, how in that long list will you ensure there's continuity through one person so that one person can actually build up trust, can know when to alert others, but can actually take responsibility so that there's continuity of observation, help, contact, and so forth?
I think that's a question, as that's an operational matter for Linda, if she wouldn't mind answering that one. We would only get involved much further down the line. So, Linda, I think you're better placed than me.
Yeah, no, thanks. I think that's been a challenge over several years, Jim. People falling through nets and criteria and cracks. As a Health and Social Care Partnership Board, we have agreed that we will all, including our mental health network teams, our community health services, local authority, all come together to work in neighbourhood teams. So you may not be co-located physically, but you're all working in the neighbourhood. And we've had a conversation actually only this week about who becomes the lead professional, if indeed it should be the resident that is the lead, if we're really going to empower people. But how do we do that in a way with the resident and the carer to make sure that people aren't passed from pillar to post? But I think that may be something, Chair, that when you come to the working group, it might be something you may want to come back to challenge, not just me, but us collectively.
Thank you. Oh, I would now like to invite Councillor Apter, please.
Did you have a follow-up question? Yeah. Sorry, I have a couple questions. Firstly, then this is probably to Linda as well. I've seen that the main takeaway from the Alison review is that the need for us to be better at spotting the risks for fire in people's homes. I just wanted to check that our frontline staff within the council, that training was going to be implemented. Thank you.
Yeah, thanks. Really good question. And I take this as a question for all council services, not just social care. So within adult social care, first and foremost, everybody who comes through the door is offered a risk assessment, a screening for fire safety. Our staff are trained to do it, and then we also liaise with the fire service. So there's a lot of protective work that happens. We've been doing some training with housing around fire risk assessment as well. And the reason why it's really important to provide information and advice. I think the challenge comes with any training is about resident choice. And the Alison is a good example of a resident who made certain choices in her life, which were absolutely right. But ultimately there was a risk there. And how we work with the residents and their families to try and mitigate those risks is the key piece. So training is one aspect of that, but making sure our policies all work together as well. So there's been training in the NHS about fire safety. Training within our local authority is still to be completed for all services, but it's well underway. I would just make a shout out to the Borough Commander, Lloyd Palmer, who is absolutely instrumental in making sure access to the fire safety team or any of his services, including him directly, is as easy as possible for us.
I would certainly endorse that, Chair. I think Lloyd has really shown us the way and worked extremely hard with his colleagues. And just to exemplify the point about it's not just social workers, at the recent Central London Community Healthcare Conference, which Lloyd was invited to speak at with his colleague Jim, that was looking at health visitors. So, you know, we really are trying very hard to make it everybody's business to be alert about the potential risks of fire.
Thank you very much. In relation to this point, I wanted to ask a question because I see on page 25 of the report, you've got the Safeguarding Adults Review information for families, friends, and carers.
Yes.
This information, I think it is well explained and it's in English. My question is, do you have this information in other community languages? Yeah.
Well, I'll ask Kerry that. I am assuming it could be provided, but I don't know because Kerry wrote all of this. I mean, before we answer that question, Councillor, I mean, I think this is a real step forward in explaining the process as straightforward as possible because we are very keen to make sure that friends and relatives of the person concerned are involved. But Kerry, could you answer that question from the Councillor?
Currently, no, it's not. But one of our priorities is to try and make the board more accessible. So it is something that we're looking at, making all of our resources, because we're creating quite a lot at the moment. So we're creating self-neglect resources, we're creating fire safety resources, and we want all of those to be accessible. So I think it is something that we need to consider as we move into the next year about how we build that into our plan, making sure that everything we produce is accessible to everyone.
Brilliant, thank you very much. Yes, I definitely agree. It's very accessible and the way it presents the information is very clear, but making sure that yes, for example, it's available in other languages so that we can reach out to other communities. I think that would be really
just to add to that, it's actually on our website, and Kerry probably wouldn't know this, but if anything on our website, we can translate it into over 100 languages. But having a printed version, no, we haven't at the moment, but it's be quite easy to translate it off the website and print it out.
Thank you very much. I'm going to go back to Councillor Apter. You had a follow-up question?
It was a separate question about the board, actually. Maybe mistaken, but having looked through the membership and also you saying that you're looking for more third sector partners, appears you don't have would be useful perhaps to have a third sector partner specifically within domestic abuse, because obviously those in care who require further support are particularly vulnerable, and that expertise might be valuable on the board. I'm aware we have the community safety team from H&F, but perhaps I'm not sure whether that's something the board has considered reaching out to.
We have worked closely over the years with Standing Together. So that's an omission, because I have worked in the time that I've been doing it with Standing Together, and they are members of both the Children's Board, which I chair, and the Adults Board. So we have a good relationship with the domestic abuse organisations.
That's great.
I'm sorry about that. That was an omission on our part, and I'll apologise to Standing Together for them not being on the list.
Thank you very much. I'm now going to invite Councillor Lloyd Harris.
Thank you. Unfortunately, I have quite a few questions, but I'm happy to sort of, just ask a few of them and maybe come back later if need, because extensive reports, appendices are excellent, very helpful. What I would ask, and this is just a very basic thing, if people are speaking to reports, can they possibly tell us what page they are referring to? Because we've got a number of documents here, and the only one that is actually has any page numbers is Appendix 3. Not really helpful, because it'd be really nice to sort of come back and say, well, okay, whatever it was on that page made eminent sense, and it may restrict some of the questions I asked. It can't be such a bad thing. What,
Well, I didn't interrupt. I agree with you there, councillor, because I've just gone through the annual report and numbered it myself. But that's a hands up from me, because when I was signing it off, I should have said there was page numbers. So
okay, thank
apologies.
you very much. I appreciate that. What I would like to know or request is that in the near future, can we possibly have a joint meeting with housing? Because obviously safeguarding, as we through these reports, hinges very much on the type of housing that's available, the safeguarding issues about obviously fires and everything else. But we have a huge problem in this borough with mold. So that has been mentioned a couple of times. So I would like to request that we actually have somebody from housing or a joint meeting so we can actually sit down and get a better understanding of what's being done, because there are problems. We don't want to lose any more residents, but it would actually help us move forward, I think, about what's being done and potentially what also the impact that we have as council on social housing, on the landlords. Are they, and I don't know the answer to this, are they given the same sort of, they have the same standards as council housing, expectations, requirements for security, for fires and things like that? Is it one and the same across the board?
Okay, who'd like to answer that question, please?
So the requirements are the same, the decent home standards, but I think we're very much, we don't look at decent home standards in safeguarding boards. We look at anything that puts people at risk, and damp and mold, yes, of course does, but we don't drill down specifically into the damp and mold and the standards. That's for housing to do, not for the safeguard.
But potentially if it becomes a safeguarding issue, and I've been to a number of flats where one specifically, and I won't mention it, that was absolutely horrendous. There were issues about health for 3 vulnerable children, and that was mold related. But there are obviously, having spoken to the mother, there were other issues. She was known to social services, but I'm just wondering if we can sort of do something a little bit more preventative work possibly, because these are the sorts of things we don't want.
Yeah, agreed. I think we just need to be clear about discussions about operational issues, about individual cases, which are picked up through a multidisciplinary team working. I know that because I chair them myself. And we have weekly meetings looking at care, complex care and housing, something which actually Keith has been instrumental in helping us to do. So I think the meeting would look at how housing safeguards people. We wouldn't look at operational issues. There is a forum to pick those up within the council.
But potentially, potentially then on that basis, there is a possibility that some vulnerable people are going to fall through the cracks. And that's actually what I'm trying to ensure as much as we ever can, that actually doesn't happen. One final question is where one's capacity for the vulnerable person seems to be in question, which obviously in this case, Alison, it is. Where do we stand legally if you say to somebody if they do not choose to take the advice that is offered in order to help them and the family are not prepared to sort of wade into it, so to speak, then who makes that decision about asking someone to sign a document saying that you agree that you're basically waiving any sort of, responsibility? It's sort of, I'll just go on with it, because if they can't show enough capacity in particular instances, are they then able to show capacity and able to sign a contract or sign a document saying that they understand what's necessary going on and they will take that risk themselves?
Mike, I'll take this. So there are 3 areas. So there is one, we have a high risk panel, which I chair along with Lloyd Palmer, where we discuss such cases. 2, we have the Mental Capacity Act that we work within for those people who are concerned about their capacity to make decisions. We always have to assume people have capacity and people have the capacity to make unwise decisions. But what we need to do when we look at fire risk or risk because of lifestyle choices is the risk to themselves directly and others about them. So if they're living in a high-rise block of flats and they refuse to comply with certain requirements, we would look at then a number of things about, is it in the best interest? What are the risks? What are the mitigating factors? The ultimate, and it's very rarely done, I think I've done it once in my career, is you go for something called inherent jurisdiction. So you go to the court as a multidisciplinary team. So myself and Lloyd and others would go to court and say, we believe this person is posing a risk. The court would then make that decision. So that's where we would go with that. To get somebody to sign something where we are questioning their capacity to do so would not be lawful anyway.
That's what I thought, but thank you for clarification.
Okay, thank you very much. I would now like to invite Councillor Obi, and then I'll invite you, Lucia.
Hello, Mike. I just want to thank I just want to first of all, thank you and is it Kerry, oh, sorry. I'm so sorry for a really impressive report. I thought it was really clear. I like the infographics, so I don't know about anyone else, but so thank you first of all. Thank you so much. Just got a couple of questions. So my first question's in relation to pages 20 to 21, but anyway, it'll be clear what I'm asking from the question. How can you make sure that all organisations comply with the same standards for training?
So we did recently discuss this at our last board meeting, and we talked about how we gather that assurance. And so the next step we'll be doing is creating an assurance template, which we will be sending out to everyone for them to confirm what training is available in their organisation and the compliance rates in our organisation. Then we'll take that back to the board then to see if we are happy with that level of assurance, if there's any more work that needs to be done. And we'll also look at when we repeat that to confirm that that is a consistent approach to training. But it is something that we are just starting on and working on now.
Oh, okay, that's great. So, but you'll definitely follow up once they return back the assurance documents and let them know about any gaps. Okay, that's great.
If I could come in there, Councillor, I mean, you pose a very, very important question, and it is a very difficult one to give you a completely satisfactory answer, because the churn of organisations means that it's a bit like painting the proverbial fourth road bridge. I know they don't paint it anymore, but you're forever having to make sure that new members of staff are given some basic or some introductory training, but also just as important is that people that have been there for some time, that training is reinforced and updated. I mean, one of the advantages of the board is that because of the seniority of people who sit around the table, we try as best we can to hold them to account for the level of knowledge and awareness of their staff. And things like the safeguarding review that we've been discussing this evening highlights where it works. And as I said earlier, it's not all about things that don't work. There is some excellent work, as I'm sure Linda can testify from the work that she does on the high risk panel. But there are some gaps, and some of the resources that we made available is a way to try and fill that gap, recognizing that many organizations, training for some, sadly, is a bit of an optional extra. But if we can make it in the most easily digestible form, whether it's through films, whether it's through 7-minute briefings, whether it's through leaflets, anything that sort of brings the message home, we try. But as Kerry said, it is a gap, and we are trying to do it. And we will be, or I will be as the chair, asking senior people to say, well, how do you assure yourself that your staff know what they're doing, to be blunt? That's what we're trying to do. And the subgroup under Helena is that they're looking at some form of audits.
Okay, yeah, thank you so much. Just my final question is that we're here talking about safeguarding adults, and I know there's a particular niche group, which is like if you're about maybe 20 or 21 and you have learning disabilities, I've seen from different boroughs that they get sort of, for want of a better word, bandied around from adults to children. So my question is, in relation to people with learning disabilities and those who don't have those as well, how are we going to transition them from being safeguarded as children to being safeguarded as adults?
Well, perhaps that is a very good question, Kat. I'll try and
I think
answer
Jo's got her hand up.
Linda, as the Director of Adult Social Services, can come in. I mean, yes, you are right. 18 is the age at which a child becomes an adult. But it is recognised in the world of children that some of the children that you describe have such complex needs that actually adulthood carries on until they're 25. So the resources that they've been given as a child carry on. I think you raise a fair point that in the eyes of many people, vulnerable adults equals aged adults. And people tend to think of their grandparents and people in their 70s, 80s and 90s, rather than, as you say, people in their 20s and 30s, who can also be vulnerable because of their care and support needs. I would like to think that we embrace all adults from 18 to 98 if they fit the criteria of vulnerability, which is described in the reports. Your particular question about transitions is, I think, something that maybe Linda can talk about, because she will be working in collaboration with Jackie McShannon, the Director of Children's Services, to make sure that children, and we've heard the expression a couple of times this evening, don't fall through the gaps, because we do recognise that these young adults do have specific needs that carries on past their 18th birthday. So I don't know, Linda, if that you can
I'm going to come in on this one, Mike. Thank you. Yeah. Thank you, Councillor. Yeah, I mean, I think Mike's spot on. I think the transitional safeguarding piece that you've mentioned, Councillor, is less about the way that the different frameworks look pre-18 and post-18, and it takes more on board the issue you raise. So for young people with autism or learning disabilities or both, or mental health issues, that transition can take a lot longer than a day. 1 minute you're a child and the next minute you're adult. And obviously perpetrators of crime don't stop at 18. They don't recognise the difference between an 18-year-old and a 17 or a 16-year-old. And because, as you rightly say, the maturity can look quite different, the issues that those young people face as they transition to adulthood are really complex. And I think the transitional safeguarding piece has been looked at nationally. There's some amazing work being done. It's looking at violent crime, gangs, domestic abuse, modern slavery, trafficking, sexual exploitation, amongst other issues that young people have to face in many of our communities. And what I think we are starting to do, and are doing very well, it is working with Jackie McShannon, but it's also working with our colleagues in health, in CAMS, with our GPs, in neighbourhoods, as Linda said earlier, to spot the signs of where young people are struggling, where they're maybe not accessing any services or support, but suddenly they come to adults with huge issues because transitions hasn't worked for them, and they need a lot of support suddenly. They're hugely at risk, being blunt. They're often very expensive to the public purse because their needs at any given point can be extensive. So the issue really is about getting to them as soon as you can. Who are the young people that are, as children, have dealt with complexity, that have got multiple issues? They're in many ways are the ones that are easier to spot and plan for. It's the neighbourhood piece is hugely attractive to us because I think you can start working with local partners like Meryl and Jim that live in the community, know loads of people in the community, and Keith, who can say, this is a concern, this child is in a family where things are really tricky. Transition's going to look complex for them. It may not be when they're 18, but it could be 19, 20, 21. And I think that's a piece that we can do a lot better on. And we've got it by the scruff of its neck, but we've got a lot to do, Councillor. Now, it would be great to bring an update back to PAC on the work that we're doing around transitional safeguarding.
Thank you, John. I think it's a suggestion as well that we have for the work program going forward in terms of transitions. Lucia has been waiting patiently, but is it on this topic?
This is a very, very quick question.
Okay.
Dr. Lang, you mentioned earlier about do that, whatever it looks like, so it can actually go in the minutes. Is that possible?
Okay, so next.
Yeah, but we're not the general public, and I assume that we all know what, you know, if you say it's not meant to be in the public domain, well, I'm sure that we can all abide by that. I would hope. Oh, okay, that's fine. Okay, thanks very much.
So just to confirm, we have to circulate that is a read guide, it's an action. Great, thank you very much. Okay, Lucia, over to you, please.
Oh. Lucy Waddington. I just wanted to pick up on an area we haven't actually touched on yet, and that's the increase in vulnerable people in Hammersmith and Fulham. And I know the report states that I think it's sort of 65 to 79 is the most vulnerable group for fire risk. And in Hammersmith and Fulham, it's gone up by 15.2%. Just looking at the recommendations that were highlighted, or the issues that were highlighted, one of the issues was to do with heavy workload, improvements with communication, perhaps, I mean, it's not a criticism, but, you know, perhaps GPs or social care not being able to attend MDTs. So I suppose my question is, if there is this increase, and I mean, I think there was another statistic I found, which is a 40% increase of people now eligible for free care in their home. And on page 70, it's mentioned as there's a 6-month funding for 2 adult social care operatives. One, I want to find out if this was still ongoing, and secondly, if there is now an increase in adult social care.
Yeah, thanks for that. I think things have moved on quite a bit since we wrote that report. So we've done a lot of work, as I mentioned earlier, about working in neighbourhoods and multidisciplinary teams. So that's now spread across the wider workforce rather than just specific to 1 or 2 workers. I think, and Dr. Lang may have a view, I think we've all felt pressure, both in terms of statutory organisations, third sector, and in fact, residents have felt the pressure of the outcome of COVID. And we're seeing a hike in referrals for social care. And that's for a number of reasons. One is the increase in or lack of activity during COVID. 2, an increase in alcohol consumption during COVID and smoking. 3, the reduction in elective surgery, which has meant that more people are now in receipt of social care or in need of social care as a result of that. And 4, as has been said earlier, the impact of housing that housing can have on social care as well. So we have seen that spike. We've seen the spike in referrals, which I always welcome referrals for safeguarding, because what it does do, it means your messages are getting out there about how to do it, how to raise a concern. And it's actually saying that, you know, our community are taking this serious. I think, as Mike said earlier, people think of adult social care and think of older people. Well, actually, we don't. We start at age 18, in fact, sooner, when we're talking about transitions through to people's death. We work with drug and alcohol users' mental health as well. So there's been an overall spike in referrals to social care, but increases in safeguarding referrals. The bit where we looked at, and we had this conversation at board recently, when we look at the number of referrals or causes for concerns, which then result in safeguarding investigations, at the moment to us looks relatively low. So we've then got to ask our question, is either our criteria too high, or are the partners who are making referrals, and a majority come from the police and fire brigade themselves or ambulance, that what tends to happen is where there is anybody that the police thinks is vulnerable, and remember that might not be vulnerable in the way that I interpret vulnerability as per the safeguarding legislation, that they put in what they call is a Merlin. So it's a report about a vulnerable individual. There's been some work in London, which Lucy, who is the police commander who works with us in the safeguarding board, is going to link us into, in actually looking at how we can reduce the incidences Merlins. But some of that comes back down to the training of the police and their ability to manage risk as well. So sorry, that was quite a long-winded response to your question, but it's yes, demand has gone up.
Okay.
Yes, we have not got more money and we will not have more money, but what we are able to do is share the workload across the wider service, but not just in terms of social care. The safeguarding responsibility sits with health, social care, GPs.
Thank you very much. Linda, do you have a follow-up question here? Sure, have you got a follow-up question? No? Okay, thank you very much. Councillor Absalom.
Apologies, just one more question, and thank you. It's really informative. I was just thinking about residents or people who might be moving in and out of the borough, and how we're able to safeguard them, or how our referrals work, or sharing those referrals with other local authorities. I was also particularly thinking about those involved in the criminal justice system who then can suddenly move quite far away very quickly. Thank you.
So I'll take the first bit, and then I'll look to Dr. Lang to talk about criminal justice. That's her bread and butter of the stuff she loves doing. Of one of many things. So in terms of where we've got concerns, or if a resident moves from here where we have a safeguarding concern and with an active safeguarding plan, and say they move to Brent, we would discuss directly with Brent what those concerns are. And we have an ability to do that under something what we call the public interest. So we do actively talk to our counterparts in Brent. And in fact, sometimes in terms of a safeguarding, if there is a Brent resident who is looked after in a home here in Hammersmith and Fulham, and we have a safeguarding concern about the home, we would likewise would speak to Brent and let them know exactly what that is and what we're doing about it. So get them involved in that. Nikki, do you want to take criminal justice?
Sure. I wouldn't presume to speak for the probation service, and it might be that maybe Chair Councillor Perez would like to invite them, because we do a lot of joint work. I know Councillor Apthorpe is also interested. So we have co-located drug and alcohol workers in probation. We fund a forensic mental health practitioner now who's phenomenal in probation. We're doing work on women, thanks to Keith Mallinson, and based at the Sulgrave Club, so female offenders, a whole sort of host of things that we do with them. What I will say is, when I have lost someone, probation will always find them, no matter where they are in the country. They often joke that they're the criminal justice agency that never loses anyone. So I'm quite confident in them. What we are working on to try and improve ourselves is people who come home to us from prison, especially on the drug and alcohol side. London is struggling with that, and we want to get better as a borough. We do have weekly meetings on who's coming home to us from prison, but we need to improve. But yeah, probation is the heart of our working lives. And thank you again, Keith, for what you've done.
Great, thank you very much. I have a couple of questions. So the report alludes to the Allison review, and there's a second safeguarding adult review. I understand that this was happening summer this year. Have there been updates? Do we know if the recommendations have come forward, and or are the recommendations also similar to the Alison Reviews case?
The report was signed off by the board in September, Councillor. I think the best person to give you an update would be Kerry, because she's been working very closely with the author of the report, but more importantly, framing the action plans, because it's great credit to Kerry that all the materials that came out of the Alison is very much Kerry's instigation. So she will be able to give you more information in respect of your question. Kerry?
Yeah, the report has been finalised. We're just liaising with the individual agencies who have individual recommendations before we publish, to make sure that they are all okay and in agreement with those. But we don't anticipate any changes to the final report. The learning that's coming out of it, there are some similarities with Alison in terms of mental capacity and assessing mental capacity, especially when someone is using drugs and alcohol. And there is also similar learning about the multi-agency communication. So in this case, there was a lot of people involved and a lot of people who are working very hard to support this individual. And there was a lot of communication, but what's come out of it is there wasn't any structured communication in terms of, there being a clear lead person, being clear actions of what happens after communication takes place. So it's giving it that structure. Again, links to some of the themes of self-neglect. So it will link to what we're developing in response in terms of multi-agency guidance on how you respond to self-neglect issues. I think the other thing that has come out of this second SAR is that this individual could sometimes be quite difficult to work with. Yeah. He was resistant to people, but he could also have challenging behaviour, including racism. So there's learning from that about also how we support staff when you're in that situation, and how you're interacting with someone who could be quite difficult to talk to and get on board with. So that's learning for us. And it's also learning about the impact that this had on staff, because as I said, there were staff that were working very hard. So we're also looking at sort of the support we give staff when they're in that situation where they're working that hard, and then you get this outcome at the end of it. So that's the slightly new bit that we have from this SAR.
Thank you very much for this update. And from this evening's report, I know the importance of that multi-agency approach, working in collaboration, working in partnership, and I know the meetings that you have, but what other steps are there in place to make sure that the different agencies or the different departments are not working in silos?
So that will form part of our action plan in response. So one thing that Quality and Practice Subgroup is doing now is they're creating the multi-agency guidance on self-neglect, which sets out standards of what we expect to see happen. And some of those will be best practice even for cases that aren't self-neglect, about what we expect to see in terms of bringing multi-agencies together. We're going to create templates to support with that. So meeting templates that guides you through thinking about what the risk is, how you respond to that risk, what your legal basis is, and then creating clear action plans with lead persons. Because at the moment, I think part of the issue is also recording. I think our reviewers, when they've been going through, there's mentions of meetings or there's mentions of actions, but it's making sure it's clearly recorded and everyone knows what's happening and when. So we're going to try and create those structures to help people do that. We're also planning workshops to sort of talk people through this as well and help them understand it, and some reflection on some sort of case examples so that they then feel more confident to take that into practice.
Thank you very much. It's very detailed. And I've got one final question. And I'm wondering whether the Safeguarding Adult Board is concerned about this. We've heard how the police will now not respond when there's a mental health call or situation. What impact do you foresee this having in terms of the response at local level?
Well, Councillor, we have had 2 meetings about right care, right person. The first one was back in August, when it was being widely reported in the media that it was going to go live on the 30th of September. And then at our last meeting, we had a full presentation from DCI Mark Staples and the Sergeant Pete, I can't remember his surname, forgive me, who's very much the operational lead. And you're right, there are lots of concerns from particularly health providers and adult social care about the impact. In fairness to the police, I think they gave a very reasoned explanation of what they were going to do. Certainly they were challenged in some areas about some of their response, the risk assessment. What we've agreed to do is to monitor it, and I met with Linda only a couple of weeks ago to discuss this. Any issues would be raised through Mark and Pete to be escalated. And then in the spring, once the new scheme has had time to bed in, we will have a proper evaluation of its impact locally. It's fair to say, Councillor, you won't be surprised that I sit on the London Safeguarding Adult Boards Chairs Network, and colleagues across London have voiced similar concerns about the response. I mean, certainly I think one of the real areas was the lack of consultation with organisations such as Mind, to name but one. It was very much done in collaboration between health providers at a senior level and the Metropolitan Police at a senior level. And one of the gaps was that whilst all this was being discussed at a very senior level, it wasn't getting down even to Lucy O'Connor's level, so that we were quizzing Lucy and she was unable to provide the answers. They have provided an explanation, which at the moment, as I said, seems reasonable. There is an escalation procedure, there is an appeals procedure. So we are very much keeping it in mind. And certainly if there is a case which has the wrong outcome for the individual, we will certainly be escalating it. As I say, I'm in discussion with Linda about it, and we will have a full review in the spring when the scheme's had 6 months to bed in. So far, Council, it started on the 1st of November. I haven't heard anything yet. I'm touching my desk as I speak, but that's where we are with it. So I don't know, Linda, if you want to add anything to that.
No, nothing more to add. We just monitor things on a case-by-case basis. So I'm touching wood as well, Mike.
Okay, colleagues, well, thank you very much. If there are no further questions or comments, we've got, yes, Joe.
Yeah, just a bit of good news, really, Council. We've appointed 2 new assistant directors in social care. So the person that'll be replacing my role is Julie Murray, who's currently the head of specialist support. That's supporting residents with learning disability, those in transition, those with autism, and those with mental health issues. And she'll be assistant director for independent living, safeguarding and quality. So she replaces Christopher Nicklin, actually not my post, forgive me. And Donna Barry, who's currently the Triborough head of hospital social work, is moving into the post of assistant director, independent living and neighbourhood services. So she'll be championing that work around integration in neighbourhoods. So we're really excited about the appointments, and I hope that you'll be meeting up with our colleagues. They both start, Julie starts actually early January, and Donna starts a week before Christmas. So they'll be fully operational from the beginning of January.
Thank you, Joe. Linda?
Yeah, just one thing, if I may, just for the minutes. Just like to thank Mike for his leadership of the board. I think I've sat on many boards over the years, and I think this is one that he's managed to retain the interest of all these statutory partners around the table, which is no mean feat. So thanks for that, Mike. And I think the last shout out goes to Kerry. Yeah, Kerry joined us and it was like a breath of fresh air. It was getting quite difficult. How do we communicate? How do we do things together? And she's just come in and she's knocked our heads together and she's sorted us all out. So thank you, Kerry, for that. An amazing piece of work. Thank you.
Well said, well said.
Thank you very much. And thank you, just to reiterate, thank you very much to Mike and to Kerry for the report, for the very detailed information, and for this opportunity where I know from members of the committee that some areas have been raised in terms of the scrutiny. So I'm looking at the actions that we have hopefully yes agreed. So the board is going to be looking at housing standards in the private sector. That's something that's going to be looking at.
Sorry, yes, we'll take that up as part of the Safeguarding Adults Board, housing standards in both private and in-house.
Okay, thank you very much. We've also asked for a link to the EC read to be circulated amongst members of the committee.
Yeah.
And there have been some questions around this consistency in training and the representation in terms of organizations that support people, survivors of or escaping domestic violence. And I'm thinking, well, some of these areas that have been raised I mean, we would appreciate if you can also take them into account. Also, I think from the conversation, I know that there are some items that we'll bring back to the committee, I think, going forward.
Yeah, we've got those noted. Thank you.
Brilliant. Okay. Well, thank you very much. I appreciate your time this evening. Thank you.
Thank you very much.
Okay, are we ready then to move on to the next agenda item? So the next agenda item I've got here my hard copy report, and it's on page 94 of the report. From page 94 to page 142. Vaccination services in the London Borough of Hammersmith and Fulham. So this paper provides an overview of vaccination programs in the borough. So we have got speakers joining us remotely, and our guest speakers are on screen. So welcome all.
Thank you very much. So my name is Susan Eldon. I'm the public health consultant working for NHSE London and the regional area. But I just wanted to say thank you to the chair and the committee for inviting us. Thank you also to Dr. Nicola Lang, Tahara, and our public health team also, who we've worked in close partnership on immunization through their own your immunization strategy and our wider immunization strategy. So there's a range of us here this evening, and we're just going to go through a presentation. I mean, we're going to try to keep it brief, but maybe just to let you know, I mean, there's 22 different vaccinations that we give across the life course. So it's a pretty comprehensive thing, but we'll try to give a pretty good summary as well as a range of who's responsible for what, and then we'd be really pleased to take questions. So maybe we'll do, I don't know whether we should do introductions of all the folks here, or we should wait until the questions and answers.
I think let's have introductions if possible, please.
Great. So do you want to go next, Carla, and then Kevin and Lucy?
Thanks, Susan. I'm Carla Hobart. I'm a public health registrar currently with the NHS England London team. Nice to meet you all.
Hi, I'm Kevin Driscoll. I head up vaccinations and immunisations for North West London Integrated Care Board.
Hello, everybody. I'm Lucy Rumbelow. I'm part of Kevin's team working on flu and childhood immunisations.
And thank you very much. And I noticed as well that from Hammersmith and Fulham, we've got with those this evening as well, Tahira Aguilar, Head of Children's Public Health, and also Dr. Nicola Lang, Director of Public Health. Thank you very much. And
we also have Anne Tunbridge, who I don't want her to be left out because she's our immunization commissioning manager covering Northwest London. So she has a really important role in advocating around performance of vaccination, particularly childhood vaccination. Anne, do you want to just say hello?
Hello, and good evening. Apologies, I missed you.
Okay, I think I'm going to kick off first, if that's all right, with childhood vaccinations. I'm hoping you can all now see the slides. I'm going to go into slideshow, so I can't see hands or anything. So someone do shout out if you need me to stop or ask anything. So I'm going to present childhood vaccinations, and I'll hand over to my colleagues who you've just met for some of the other wider vaccinations across the life course. as we go. So before we get stuck in, I thought it was just first important to set the scene really in terms of roles and responsibilities, because there's a quite complex picture, as you can probably see here, and hopefully you've got this in your pack so you can see it a bit better, of multiple organisations working together to deliver the immunisation programme, ranging from the national all the way through to the hyperlocal. So just running through them, as you'd expect, the Department of Health and Social Care set national strategic direction, and they take expert advice from the Joint Committee on Vaccination and Immunisation, the JCVI, that I'm sure you've all heard of. And you would have seen examples of their sort of recommendations perhaps in the news recently, with kind of new recommendations from them around things like chickenpox. And then NHS England kind of take that national strategic direction and commission the providers in line with that. And we obviously contract manage those providers as well. But I think it's really important to note that the kind of regional London architecture can obviously only go so far. It's really important that our kind of more local partners then shape that provision. So the Integrated Care Board plays a really key role, and you will hear more from them later, in having the relationships across the system to improve vaccination services, especially through GP surgeries, who are really, really critical provider of childhood immunisations. And actually, we also expect that the NHS England commissioning responsibilities will, in time, and we're not sure of the exact timelines around this, be transitioning across to ICBs for vaccinations as well. So that's just worth bearing in mind. We also then have a whole host of different providers, all doing slightly different things over slightly different geographies. So we've got maternity services, outreach services, GPs, school age immunisation services, and others, all delivering vaccinations at different parts of the schedule. So it's quite complex. And then obviously, crucially, we have local authorities such as Hammersmith and Fulham, who've got such a key role for us in shaping this provision and maximising access, engaging residents, and promoting uptake in ways that best meet the needs of your specific communities, your local areas, and with your local infrastructure. Kind of layered on top of all that, we've got the UK Health Security Agency, who have more of a surveillance role, and they also lead things like response to outbreaks of vaccine preventable disease as well. So overall, all of these stakeholders are aiming to work together to provide good, accessible services married up to local need, and we all share responsibility for delivering that. So I think meetings like this really assist us in terms of making sure we're all working together to improve performance for the local population. So I've just included a quick reminder here of what vaccinations happen when in childhood. And the reason I've just included this is just to mention that we tend, when we're thinking about vaccination performance, to focus on some particular vaccinations, and I'll explain why. So the first one to note is the 6-in-1 vaccine that you can see there. We have what's called a primary course at 2, 3, and 4 months of age, so for babies. And that vaccine protects against diphtheria, tetanus, pertussis, polio, Hib, and Hep B. And the reason we really try and kind of use that as a good performance measure in terms of uptake is it's administered at the same time as lots of other vaccines, so it's a good marker for how we're doing. It's administered when babies are very young, so it's a good way of us seeing if our broader primary care services are serving families and young babies. Are we accessing those families? And the other reason we look at it as a good marker for vaccination performance is that it covers polio. And as I'm sure everyone is very aware, we've had that additional focus on preventing cases of polio disease and the spread of the virus since poliovirus was detected in London wastewater. And I think Susan will correct me if I'm wrong, but I believe we are now happily free of that in London wastewater at the moment. So that's great. And then the second vaccine we tend to focus on, which will be no surprise to you, I'm sure, is measles, mumps, and rubella, or the MMR. And we tend to focus particularly on that as a key marker, as we have not as a country reattained our measles elimination status. We are at risk of measles outbreaks, particularly in London, due to our suboptimal MMR coverage. That's a really key focus for us. And there's a national ambition that we share regarding measles and rubella elimination in this country. I think we're probably all aware of the very significant risks measles can present, and so we are really striving to achieve what's 95% coverage of MMR and all our childhood vaccines to protect against outbreaks. And before I launch into the kind of specific performance data, I think it's just also worth noting that we don't just consider the overall 95% coverage. We also think really carefully about the chronic inequalities we see in London in terms of vaccination uptake, just as we do for other measures, by deprivation, by ethnicity, by geography. And we are really focused on tackling those inequalities as well as overall vaccination coverage for these and other vaccinations. So in terms of performance then on the 6-in-1 vaccine that I mentioned, unfortunately, as you can see, Hammersmith and Fulham performance is on the left and is slightly below that of London in the middle, and certainly below that of England overall on the right-hand side there. And you can see that both when it's measured at 12 months of age, which is the sort of greeny line, at 5 years, the red, and for the booster that we give in the yellow line. So there's definitely sort of some plateauing trends here that we're struggling to reverse over this timeline, as you can see. I would just note when we're looking at this performance that it isn't sort of absolutely current. So some of the work we're currently doing around catching children up won't be reflected here, but this is obviously not where we want to be. And this is reflected again with MMR. So again, we're trying to achieve that 95% coverage target, and you can see that as the yellow dashed line, and we're not unfortunately achieving that for Hammersmith and Fulham, nor for London, nor unfortunately for England as a whole, as you can see. We are seeing perhaps some slight improvement in the first dose of MMR, the purple line, but we're still hovering really at around 80% coverage, which just isn't enough to protect us against outbreaks of measles. London has already had outbreaks, and many of these have occurred in northwest London, so it's really relevant locally as well. So we've obviously got lots of actions in train aimed at trying to get back to that 95% coverage target. And I'll come on to some of those now. So the first thing we're doing regionally across London is a focused MMR polio catch-up campaign. And what we're really trying to do here is focus really intensely on the children who are either under vaccinated, so they're missing some of their doses, or are unvaccinated for MMR or polio. Really trying to catch those children who have no or insufficient protection specifically. So that's involved a phone call approach to every family with a child who appears to be under or unvaccinated in our data, to discuss that and seek to see if we can arrange a vaccination event for that child via school or community clinics. And we're really closely monitoring the total number of un or under vaccinated children. So in Hammersmith and Fulham, this is about 9,000 children that fall into that category. And all of those families, I believe, have had an attempted phone call, but we do struggle with getting up-to-date contact details for families, so we don't always manage to speak to those families. We're also facilitating borough leads to liaise with the vaccination provider for this. For Hammersmith and Fulham is Central Northwest London, and trying to arrange a venue or venues that work for your borough to catch up vaccines prior to Christmas, or offering a range of catch-up clinics. I think currently the catch-up clinic for children in Hammersmith and Fulham is at the Pet Quarter Centre, so we can give more details of that if that's useful. And then underpinning all of that activity of calling children and laying on extra clinics is work with schools that have particularly low rates of immunised children, and with seeing how we can interact there as well. And there's also kind of a broader communications campaign running at the same time. And then there's a whole host of other actions, sort of both at the regional and local level. I've just listed some of them here, but there's lots more information in the report that you can kind of dive into as well. But these actions range from things like immunisation coordinators working specifically with individual GP surgeries to make sure their data is right and to help support them with things like call and recall systems with parents. From roving teams that the Integrated Care Board team may touch on shortly, and a whole range of other actions at the more local level that Nicola may want to speak more on later as well, but things around specific venues. I'll just pause for a minute in case any of my colleagues wanted to say anything more specifically about childhood vaccinations before we move on to seasonal.
Just to jump in, Carla, in terms of the outreach clinics, just to let colleagues know that in Northwest London we have a roving team which supports outreach into underserved communities, those communities who perhaps have a historical low vaccination uptake. And what we are doing in terms of next steps for the outreach team, roving team, is to work much more closely with our local authority colleagues in terms of community engagement teams to support facilitated access into some of these communities, because we know just setting up clinics and expecting people to turn up is obviously not going to produce the outcome that we want. So the next steps for us really are to work much more closely with our local authority colleagues, and we'll be doing this across all of our boroughs in Northwest London, to use data to understand where we need to target the roving team in terms of their outreach provision. Then use our, as I say, local authority colleagues and engagement teams to support with discussions and facilitated access, and then to run those outreach clinics only after all of those things have been done. And we know from experience, unless we do that, as I say, we're unlikely to see the impact and improvement in uptake that we would want to see. So just to reiterate that, that's part of the model that we are currently rolling out across Northwest London, including in Hammersmith and Fulham.
Thanks, Kevin. If there's nothing else on childhood, actually, I'll hand over to
Sorry,
Kevin.
Ella, bring me a second, please.
Sorry, may I just interrupt for a minute? Can I just ask, did you misspeak a minute ago when you talked about Peckwater? Because that's not in our borough. It would be helpful if we could have a reflection of what's the situation in our borough.
Yes, so that is the nearest at the moment. I think, and Anne may want to update me if there's anything new. I think we need to just facilitate liaison between the vaccination provider, Central North West London, and the borough public health team, just to see if there's more appropriate locations essentially for Hammersmith and Fulham. So we know that's not optimal. Yeah.
Okay, so as an action, do we want clarification of the location then?
I think, yeah, we kind of just need to work together essentially just to see if there are some good, appropriate community locations and how that might work. So yeah, that was an action.
That would be helpful. Just to clarify, if I may, with your permission, Chair, are you committing to find community locations in Hammersmith and Fulham?
I'll just defer to Anne in case there's anything I've missed, but I believe that certainly is the aim, and we're looking to do that. Yeah, absolutely.
That's a commitment.
Yeah, we do want to do one in Hammersmith and Fulham. We want to do them in all boroughs. Yeah.
I think Anne's on mute, but just to say, I mean, we can provide the list. So there's definitely, Lucy and Anne will have this, and sorry, I should have this at my disposal, but there's, for the childhood side, we have both flu and we have MMR clinics. We can provide the list following this meeting and make sure that colleagues have that through our SACE providers. Thanks.
Thank you very much. Please carry on with the presentation, and then we'll move on to questions.
Thank you. I'll hand over to Kevin.
Thank you, Carla. I think you're controlling the slides, so if you can please go to slide 10. The seasonal vaccinations obviously centre on flu vaccinations and COVID. COVID is now falling into a cyclical seasonal campaign. So we generally see COVID vaccination campaigns happening in spring. and in autumn. So we're currently in the autumn 23 campaign. JCVI, so we've already heard from Carla in terms of the Joint Committee on Vaccinations and Immunisations. They tell us on a regular basis who we need to be vaccinating in terms of eligible cohorts. And this year, we've almost aligned eligibility for flu and COVID. The only group that falls outside of that are school-aged children who are entitled to flu vaccinations but aren't eligible for COVID unless they are in a clinically at-risk group. So we've got all of the eligible cohorts here. I'm sure you are already familiar with these groups. Our delivery model is really based around how we can reach these groups effectively. And the autumn-winter campaign kicked off way back in early September, the 11th of September, when care home residents, immunosuppressed and other clinical groups were the first to go, but particularly care home residents for obvious reasons. And the COVID vaccination autumn-winter campaign had an accelerated element to it. So the government and Department of Health asked us to vaccinate care home residents by the 22nd of October. And providers stepped up to meet that challenge and actually have managed to visit 100% of care homes across London and in Hammersmith and Fulham. And the current uptake for North West London as a whole for care home residents sits at just over 82%. So that's the highest we've ever had, well, certainly in the last 2 or 3 campaigns. So real massive effort for all of our providers, including those in Hammersmith and Fulham. The next slide really is just looking at some of the key actions that we've introduced. As I say, a lot of our focus has been on that accelerated part of the autumn-winter campaign, focusing on those very vulnerable groups. The other key bit to this campaign has been to bring together a joint offer in terms of COVID and flu vaccinations through co-administration. So that's always going to be the default offer for both of these vaccine types. And all of our providers, well, in most cases, will have access to both flu vaccines and COVID vaccines, whether that's being delivered through a primary care-led offer, community pharmacy offer, or indeed through the roving team offer across North West London. So we obviously are maximising opportunities to protect the most vulnerable this winter through offering both of those vaccine types. There's obviously been a number of mutations and variants of the COVID-19 virus. The latest being the XBB subvariant, and we have a new vaccine type, well, relatively new. It's been available for the last month or so, and providers are now using that XBB vaccine to administer to those vulnerable groups. We obviously have a very large number of community pharmacies. In fact, about over 80% of all of our capacity across North West London is delivered by community pharmacies. And we're really keen to maximise that delivery pillar going forward as well, because obviously community pharmacies have access to both flu and COVID vaccines, but they also have that relationship with their customers, and they can talk to them about any issues they might have around vaccines, and whether there's any issues they need to be made aware of. Then obviously pharmacies can do that. But also looking into the future, I think we've already mentioned the delegation of responsibilities. So a lot of the commissioning responsibilities over the next 12 to 18 months will move from our regional colleagues to ICBs. So we will have much more of a focus on commissioning community pharmacies going forward, and we want to maximise that opportunity to look potentially at pharmacies offering other vaccine types as well. In terms of the both elements to the programme, so both for flu and COVID, there's obviously a key communication package and a plan that supports what we do, and we invest quite heavily in the information that we send out through our distribution channels and the information we hold on our North West London website. We list all of the locations that are offering both COVID and flu vaccinations, including the 161 community pharmacies that form part of the offer across North West London. You currently have 19 community pharmacies in Hammersmith and Fulham. You obviously have the 2 hospital hubs and Parsons Green, which is also offering vaccinations to frontline staff. So we have a fairly comprehensive offer as part of the autumn-winter campaign. And the next slide really, excuse me, is just an overview of the plan. So in terms of every campaign, so that's twice a year, we have to put a plan together for NHS England. We have to do an infrastructure plan. We have to do a capacity plan. We also have to plan for surge scenarios. So we have to be able to scale up within 10 days to match any surge situation. You may remember sort of 18 months, 2 years ago, we had the Omicron variant where we had to step up and maximize our coverage to meet that challenge. And so we always have to be aware when we go into a new campaign that there may well be a change in circumstances. We may see a new subvariant emerge, which is more severe, and we have to maximize the offer to those eligible groups. The other key things that we do, and data's already been mentioned, but we do use a lot of our qualitative and quantitative insights. So as part of the work we do, we gain a lot of insight. We collect a lot of data, and what we are starting to do, we've done for some time now, is use that data to understand where we have low uptake, hotspots. We use mapping to understand differences in populations. I've got a couple of maps to show you in a second where we really focus on those eligible groups that I've mentioned and where they're located in those particular wards, in those particular boroughs, and actually how we can utilize all of our resources, all of our providers to offer a comprehensive offer to those groups. So the next slide is one of those maps that I've mentioned. So what we do as part of our planning is sketch out all of the infrastructure. So that's across all of the delivery pillars. So those sites which are led by primary care, the community pharmacy sites, the hospital sites. And the reason we do that is we look at the locations and ensure that wherever possible, an individual resident is no more than around 20 minutes travel time to a vaccination site. And that's a challenge we set ourselves every single time we do the plan, to ensure that accessibility is key in terms of being able to plot our infrastructure and to make sure that those that need to benefit from a vaccination are never too far away from a vaccination site. And then the other map that we use, and again, we use a number of maps, so I'm just using this one as to illustrate the thinking behind some of the planning. Obviously, 65 plus population are a key eligible group in terms of an age specific group. And what we've done with this map is look at high densities of where we have populations who are 65 plus. And as you can see, pockets in the south of your borough where we have high numbers, relatively high numbers of people who are 65 and over. And what we're doing there is looking at making sure that that infrastructure meets their needs. So as you will see, we've got a number of community pharmacy sites there, which are very well located to some of those population density areas of populations over 65. So that is a key bit. I don't know, Lucy, did you want to add anything else from a flu point of view? Or do you think we've covered it?
No, nothing to add. I think it's pretty much covered it, all of it.
Okay, and in terms of next steps, overall, I think Carla, you've already touched on the work that's going on in terms of the work around improving MMR uptake. So we're moving into a phase 2 of our sort of polio MMR program, which is really focusing on those unvaccinated or partially vaccinated children, of which we have relatively high numbers. But we know that actually just using a call and recall process, in other words, just doing what we always do, is not really going to reach some of those parents who so far have not come forward through being contacted by their GP on 3 or 4 occasions. What we need to do is look at a different approach, maximize that primary care offer in terms of call and recall, absolutely, but actually use a different approach in terms of outreach. As I've mentioned previously, from a system-wide perspective, we are lucky that we have a roving team offer, and we are going to maximise that offer through the plan that I've mentioned just now in terms of organising that approach around community engagement, spending, investing in terms of building those and sustaining those relationships with those community groups who are potentially vaccine hesitant, and then provide an intervention in terms of running those clinics. And the roving team are currently just about to appoint a community liaison officer, and that role will link in, as I say, with the local authority community engagement teams, but also they will link in directly with voluntary and community sector, those community groups who have the trust and are articulating the voice of their communities. Those are the groups we want to work with in terms of improving uptake. So a lot of investment going into to support that approach over the coming weeks and months. In terms of the general ICB plans, obviously we're developing those plans around the MMR polio catch-up, focusing on those children 1 to 4 that are unvaccinated or partially vaccinated. As a system, we have a North West London immunisation board, and we have public health representation on that board, and that board has been running for around 18 months, and that provides scrutiny and challenge to what we do in North West London, including what we do in Hammersmith and Fulham. And we have to produce monthly progress reports on areas where we have potentially underperformance, and look at action plans and introduce actions to improve any underperformance across our work streams. It's just useful just to mention that vaccinations are not mandated, and we are reliant on parents, on individuals choosing to come forward for a vaccination, regardless of what that vaccination is. And that will tell you that often we're up against behavior, we're up against often anti-vax sentiment, and we've seen a lot of that across different systems over the course of the pandemic, and since the pandemic has formally come to an end, but we're still seeing that anti-vax sentiment. So we have to work with things like behavioral insights, how we can work with parents, how we can work with individuals to try and move them from a point of view where they're saying, I don't want to be vaccinated, to a point where they are taking up the offer of a vaccination. And that's a process, motivational interviewing type processes where you are moving somebody who's potentially ambivalent about taking up the offer of vaccination into choosing to make that choice of being vaccinated. So that's the kind of work we're doing, the qualitative work that I've mentioned already in the background to improve overall performance, and particularly, as I say, in those areas where we need to really step up, where there are clear, stark inequalities, particularly in those underserved groups. So I think that's it. The recommendations, I think, is that one for you? Is that for me to oversee this one? Health overviews. Yeah. Is
that's for us. Thank you. Thank you.
Okay.
Thank you very much. So thank you, Kevin, Carla, Susan, and Anne. Before we move to questions, I would like to please invite Tahira de Aguilar Chavez, our head of Children's Public Health, and also Dr. Nicola Lang, just to give us please an update as well of the work that's happening in terms of public health vaccination initiatives and any concerns that you may have.
Thanks. I was going to ask David, could we put the slides back up? Because Tahira's slide was, is it there? They're there. Okay. Just the last one is Tahira's.
It could be the last page of the report.
Yeah, it's in the pack. I don't know, Susan or Carla, could you put the presentation back? And it's just the last.
It's not on my copy, but I will try and find it.
It's not in your
Give me a minute.
Okay.
I think we've got the slide. So between the two of us, one of us will find it and we'll flash it up on the screen.
It's colorful and it's got,
It's right at the back of your
it's green and red.
So in your reports pack is the last page. So
Yeah.
it would be the last page of your packs.
Yeah, Tahira can
Page
talk through it.
142.
I'll
So-
find it for you. Sorry. Oh God.
It's the last one.
Oh no, do you know what? It wasn't on.
I don't think it's on the
It's on the
slide.
Yeah, it's in the pack. Sorry.
Have you all got it?
Yeah.
Yes. Okay. Oh, thank you very much. Yes, it's on the screen. Thank you very much.
Okay, so in terms of the public health team, we've looked at how we can try and tackle the issue of childhood immunisations and trying to do it from a little bit more of a innovative standpoint. I think the main focus is engagement with our communities, but in engaging them in a slightly different way, which is around in using the information that they already have, and that's very readily available, but also tackling some of the questions that they had around it. So around the way that immunizations work on the immune system, that was a kind of a big kind of dialogue when we'd had some of the listening conversations. I remember quite clearly when we spoke about COVID and we had immunologists around to talk to residents, but some of them didn't quite understand what the immune system was in relation to needing a vaccination. Why would you need a vaccination as opposed to just being really healthy, eating well, etc.? So we collaborated with an artist to come up with an infographic which explains the immune system from a scientific way, but also as engaging as possible. And the idea for this is for it to be up in GP practices, be up in children's centres and family hubs, so children can have a conversation with their parents about it, because it's a nice, engaging cartoon infographic. But also when someone like a health visitor or a GP wants to have a detailed conversation with parents talking about the immune system specifically, that was a thing. So we've sent that out to GPs. We're trialing it with a school to develop resources. So we'll have to distribute that to schools, so primary schools can have that conversation. That's in a suite of a package of other interventions with schools. For example, explaining that if you have the if you have interaction with someone with measles, it would mean that you need to be excluded for 3 weeks because of as a measure. So that's a kind of trying to package it together in a bit more of a coherent way. We also wanted to make sure, so we use that as a way to enhance some of the training for health visitors, so that they can feel confident having conversations with new parents and families about immunisations, and utilising that as a bit of as a resource for that. We've also recruited recently, who started on Monday, a senior lead for public health nursing. So she will be available in family hubs, talking to parents about things like not just vaccinations solely, that wouldn't be her main role, but build that community relationship. So she's a trusted member who can answer questions for parents. And then we've done some more targeted community engagement work with Somali communities, but also other faith forums, so working in mosques. So one of our IPC nurses, infection prevention and control nurses, has worked really carefully, really closely with faith forums and mosques, delivering conversations around immunisations. And then one of a focus, I think it started last year, in care homes, really making sure that there's training for all the care home staff to explain what vaccinations are for, why it's important for them to take up, because we want care home staff to take up vaccinations because the vaccination rate is low there, but also having that open, clear discussion, and they can have that, a two-way street rather than forcing information, which our residents have said that that's how they feel. So we're trying to have more of a dialogue there, and making sure that our residents, as much as possible, have got good coverage in the care homes. And so the infographic is also available on the webpage, and it can be translated to all of the 100 languages. As Linda said about anything on our website is able to be translated. We're looking at working on developing a group of kind of ambassadors for health, young people, ambassadors for health, again, working in faith groups, so working with the mosques at the moment, and thinking about young people as being real advocates for health. So that's also one of the reasons why having that dialogue in primary school to talk about it with children, so they can understand the science behind it. And you would be surprised about the technical language that a 7-year-old gets exposed to in a primary school. Some of the grammar words that my children spoke to me about, I don't remember if I learned about that when I was in primary school. So complex terminology, I think, is important to use the right terminology, just so when people are doing their own piece of research, they can have the right tools for them, really. So I think that's, in a snapshot, what we're doing in H&F.
Yeah. Thank you very much. Dr. Lang, do you wish to supplement?
Nothing to add. We had a vaccine pop-up, thanks to Kevin, at Almontada Mosque today. Very low vaccination take-up, unfortunately, but good health checks. So good take-up of blood pressure and other health checks. It's the beginning of a dialogue. Next will be Egyptian House, Our Lady of Fatima. But Almontada have been such great friends to us that we thought we'd start there. So thank you, Kevin.
Okay, thank you very much. Okay, I would now like to move on to questions from the committee. And I know Councillor Bobby has his hand first. And then Keith. Of course. Bobby? Yeah.
Hello, I've got a couple of questions. The first one is, I'm really sorry to say this, but I feel like I'm living in Groundhog Day. We have consistently had a poor uptake with all manner of vaccines, MMR, flu, COVID, in this borough for many, many years. What are you going to do about it?
What we're going to do about it? What we're going to do about it is what we have been doing about it to a certain extent is making the offer as accessible as possible, and we've done that through creating the infrastructure, and then promoting that offer to your residents and to residents across Northwest London. as I say, the challenge we have is that the vaccinations are not mandated. And we have seen vaccine fatigue. We've seen, as I say, anti-vax sentiment, a whole range of challenges around vaccination uptake. We continue to support, and as Nicola has just outlined, when we run clinics in settings where often communities do have low vaccination uptake, we still get low vaccination uptake. And that's through facilitated discussions prior to these vaccine clinics taking place. We want to do more of that. As I said, in our model, we want to put community engagement at the forefront of what we're doing around vaccinations and immunizations, as I say, because we know just running clinics won't have the impact, won't necessarily improve uptake. But, you know, that's an ongoing set of discussions that we are having. The first point is to make sure, you know, vaccines are available, accessibility is easy, it's spread across the borough, not centered on one particular area, but, you know, people can access it within 15 or 20 minutes. So we are doing lots. We still have to do more, absolutely. But as I say, I think we are fully invested in making sure we focus on community engagement as the first principle.
Thank you very much. Councillor Wilby, you have a follow-up question.
Yeah, just a final follow-up question. But before I ask my follow-up question, it's implied through the reports, not really stated, but implied, that the problem is the provision of staff. Because if it was about location, I mean, I'm sure I can't speak for the borough, I can actually as a councillor. We have 145 King Street, which we're always willing to open to all services. So if it's, I suppose, if it's a problem of you guys not being able to find staff, it's not really our problem in the politest sense possible. Just a follow-up question. I was actually, you know, full disclosure, I've been vaccinated against COVID-19. However, I was actually quite surprised about this sort of categorization of sort of, you know, I'm paraphrasing it, mad hatter anti-vaxxers. People may or may not know this, but there's a lot of distrust actually in a lot of communities. There's evidence, medical abuse amongst Black communities, namely the medical abuse against African American communities, and even, you know, disastrous cases of experimentation in the north of Nigeria.
Yeah.
Why I bring that up is, of course, like, you know, let's say Black communities in the UK are not necessarily of African American heritage. So you may wonder why that's actually relevant, but it's relevant because a lot of things in Black communities are transferred through oral history. So again, if you're not a direct descendant, it doesn't really matter because there's an oral history there. So my question is, what are we going to do differently to reach our Black and ethnic minority communities? And second of all, I've heard the word underserved used, like who's underserving them?
Really, really valid points. And I would not put you know, that description in with anti-vax, because anti-vax is something completely different. You know, absolutely not. But you absolutely make valid points, and all fair points, you know, in terms of the mistrust of healthcare services, the mistrust of vaccination programs by certain communities. You know, we have a lot of work to do to engage communities and to build that trust. And I'm not underestimating that challenge, you know, and we accept that challenge in Northwest London.
Can I maybe describe a few additional things to help answer that question? So
yes, go ahead.
Okay, so on the first question, I thought that was a really valid question in terms of what are we doing about improving performance. I wanted to just give maybe a couple of examples of what we're doing. And primarily one of the things that you're talking about is about equity. And so you might know that when we first found out that there was polio in increased measles, what we did was we gave booster doses to everyone. And what we discovered was that the worried well came forward. And so we boosted the worried well. And what we have done in phase 2, learning from that, is we've said, we're not doing another booster dose. We're actually going to find the missing kids. We're going to see if we can locate them. We're going to try to contact them 3 different ways. We're going to telephone them. We're going to try to get data from the schools, and we're going to text message, and we'll give 3 different ones. And what that has revealed is we have a lot of kids missing. We have a lot of kids that are unregistered with practices, and probably similar to the presentation before is there's a lot of safeguarding issues. There's a lot of complicated people who live between different locations. And so we're having to work quite closely to follow up these kids. The other thing that we're doing to improve access and equity, and this is what we can do from a service perspective, is, we roll out e-consent, particularly for children, to make sure that parents can consent. When those parents don't consent, and some of people don't use digital technologies, we do a paper consent. Then when we consent them on the day, we sometimes get quite a bit of pushback from parents saying, no, we actually don't want this. So there's a kind of delicate balance that Kevin was talking about in terms of keeping trust with people. And some people are on the resistant side, that they don't want vaccination. Some people are just very skeptical, and some people are very busy. So we try to tease out those areas. I really wanted to address the issue you're talking about, which is about structural racism, which is something that we take very, very seriously as an institution and organization, as well as what we need to promote and do better within vaccination. The history you're talking about and our relationship with communities has historically not been as strong as it should be, could be, and needs to be going forward. And so a few things that we are doing and going forward, in all of our new contracting, we stipulate that our contractors hire people from within communities. We have 3 different initiatives, particularly on the Black and ethnic minority. One is called the Black Inspire Health Network. We also have faith leaders, the Muslim Health Network. We also cater to individual faith needs and cultural needs, such as providing vaccine alternatives for people who may not want porcine injection and things like this. We recognize that none of this is enough, but these are some of the measures that we're trying to take from a service side. But I think Kevin's point about demand was equally important. We are seeing a decrease in demand overall.
Thank you, Susan. I would now like to invite Keith Allison, please.
Yeah, hi, thank you. I think you are doing an awful lot of work, and that's a good thing. But I'm just wondering if you are really working with the right people. When you talk about faith communities, the Somali community, that's all very well and good. But the organization I work for, and many others, were in the same situation. We're working with vulnerable families. We're working with vulnerable people whose grasp of English isn't terribly good. Now, I haven't seen anything at work about vaccinations and things, yet we have drop-ins every day. We do food distribution, clothes distribution. We have coffee mornings. We have parents liaison. Now, I'm sure there are others like us, but why aren't we involved in this? We can talk, we understand our clients, we can talk to them, and we're not talking them from up here, we're talking from them at their level. So what I would like to ask you is, can you just maybe look again at who you are working with? One thing you mentioned, the Somali community. A lot of our clients are Somalis, but they won't engage with their own community for various reasons. So I think that's something. It's all very well when you work in the bubble of bureaucracy and things, and we work with this partner, we work with that partner. But I think you need to look outside a little bit. Thank you.
If it's okay, I'd like to take your details because we are building that model that I mentioned earlier in terms of community engagement, and that's a broad term, you know, to include all aspects of community. And the roving team, for example, have run clinics in food banks, for instance. So you get, you know, a wide range of people and communities accessing those type of support services. And, you know, often they've had queues of 70 or 80 people waiting to see them because they are registered healthcare professionals who are working as part of that team. So absolutely, we want to build on what we have done, and we've still got a long way to go. So if I can make sure I've got your details, we will make sure that's put fed into to the model that we are developing in terms of outreach.
Okay, thank you. I think Tahira, do you want to come in?
Yeah, I was just going to say about working with individual communities. So we are focused. One of our IPC nurses is working with individual communities, but you're completely right that it's not just one group. And one of the issues that we have is that there are some community leaders or organizations that are quite vocal and often have a lot of our interaction, where we're trying to move a little bit more aside from the most vocal ones and think about the ones in different contexts that parents will get involved with. So we're thinking about things like the family hubs. I think that's quite an important one, different areas of groups, redeveloping, thinking about some of our kind of community volunteers who might be working with groups, rather than it just being big organizations necessarily, because invariably we'll miss chunks who don't engage in that in those groups. And to another point that I'm going to pronounce your name so wrong. Genevieve is the easy bit, but I was going to do counsellor. I was trying to be polite. To come back to your point, I think it's really salient for us to consider some of the and to be frank, structural racism, historical issues that we've had around people from Black backgrounds, and I just do the blanket term as Black. I feel like I can because I am the blanket term of Black rather than differentiating. There is an issue. So we're looking. The next phase for us in the public health team is actually trying to have a dialogue around what people do know and what is right. So things about their health. It's not that they're health disengaged. It's not that they don't understand or don't trust medicine completely. It might be specifically about this one thing. So we can't lump them as you said, you know, crazy. It's about, you know, that's one of the angles why we came with the immunization as a support for your immune system. So that is noted, and that's kind of the next phase from my perspective.
I think Linda, you want to supplement? You've got okay. Thank you very much. I've got an order here. So I've got first Councillor Lloyd Harris, then I've got Meryl, then I've got Jim, and then I've got Linda, and then I've got Councillor Coleman. Thank you.
Thanks very much. I noticed that you said that we've got 82% only of people in care homes vaccinated. That seems very, very low given the issues we've had previously with COVID. So what are we doing to raise that percentage? Because that actually is quite disturbing. So we've got the older age group in care homes. We've also got the young. I'm assuming those in between are pretty well vaccinated, but if we've got 9,000 young people that seem to be under-vaccinated, then it is part of the issue that maybe some people don't have access to a GP, where a GP would know the family and might say, have you been vaccinated? So that would be, I would have thought, an ideal place to be. But if people can't get access to their GP, that facility is going to be lost to many people. And we know that more, as one gets older, you're more likely to be seeing a GP. So there seems to be a little bit of work that we should, or hopefully that we could do there. And just one final statement or question is actually about, there are people in our community who do not historically, ordinarily would have a vaccination from a nurse or a pharmacist. They would be usually expecting a doctor to do that. And I know this has been raised before when we were talking about COVID. So what are we doing to educate people that here actually it's more than safe to have a pharmacist or a nurse give you your vaccination? It doesn't have to be GP. Are we doing anything about that? Thank you.
Yeah, I mean, in terms of the first point, care home uptake, we've never really seen that level of uptake in previous campaigns. You're never going to get 100% uptake with any group. You know, people still have a choice to either say yes or no, obviously, and care home residents can make that choice. And so the 82% is probably one of our highest for quite some time. The team obviously go into care homes. They work with care home providers to provide as much information as possible. They work with families of care home residents where necessary, to get consent where necessary, and obviously work with the relevant GPs who cover those care homes as well to make sure that things are lined up. But we can only do what we can do, and I think 82% is relatively high when compared to previous campaigns. We want it to be 100%, and the team make it as easy as possible for care home residents to take up the offer of a vaccination. But we're never gonna. The reality is, we will never have 100% coverage. There will always be people who choose not to have a vaccination. In terms of young people, yes, we do have, there's a data set, Child Health Information Service, which is CHIS data, which does look at unregistered populations, including unregistered children. So we do have a view of those who are unregistered and can provide an offer. So in previous campaigns, letters have been sent to parents of unregistered children through the CHIS data set, offering either for them to register with a GP or providing information on where their child can be vaccinated through outreach clinics or clinics that are taking place in those localities. But understanding more needs to be done, but there is a system to identify unregistered children from that perspective. And in terms of vaccination by other healthcare professionals, well, in actual fact, we are seeing more vaccinations taking place in community pharmacies than any other delivery pillar. So actually the vaccinations in pharmacies make up a significant number of our overall vaccinations, both from a flu and COVID perspective. So, and we want to build on that. As I mentioned, community pharmacies are best placed in many cases to have conversations with people if they are vaccine hesitant, and they've got that trusting relationship with their communities. So yeah, we are seeing other professional groups vaccinate. And in fact, one of the legacies from the COVID pandemic is that we trained fairly large numbers of unregistered vaccinators. So people were put through a fairly rigid training program, supervised appropriately by registered healthcare professionals, etc. But to reduce the strain on the NHS and the health service more generally, we trained people who were working in other sectors to become vaccinators. So we are seeing that option as well in terms of other means of vaccinating people, obviously within the relevant safeguarding principles and making sure that these people are appropriately trained. But that was something that happened during the pandemic.
You've got a follow-up question, Councillor Longhurst.
Yes, just a quick follow-up on the care home. Is the 82% only those that reside in the care home, or are we talking about staff? Because, well,
just residents.
Just residents.
Yeah.
So do we keep any sort of statistics on those that work in care homes? Because I know there was a suggestion that, don't know how politically correct this is, but anyway, that those that were working in care homes needed to be vaccinated, and there was a strong push to have them vaccinated.
Yeah.
Accurate?
Well, it's not obviously mandated for care home.
No, I
staff.
understand it's not mandated, but that was the discussion I had with the previous director about ensuring that there wasn't a further spread of COVID and obviously other diseases. So I'm just wondering what about staff generally.
I think Dr. Lang as well wants to come in. And
Thank you. Thanks, Councillor Lloydhurst. This is fascinating because last winter we had the first year of our head of infection control doing detailed qualitative work with all the staff in each nursing home. The worst nursing home coverage was about 11% and the best one was 36%, which for them was a big increase. This winter, we're hoping to build on that and go even higher. What I found fascinating was sometimes the reasons for not being vaccinated weren't what Tahira was mentioning. It was actually, I think I'm going to feel ill the next day and then I won't be paid. So we found this whole undercurrent of what we didn't expect. It was lost pay. So we always think, as Tahira said, they don't understand immunology. Actually, they understood it. We also acted out the immune system with healthcare staff. We did everything. And it was the basis for Lizzie Naylor's master's in infection control. Absolutely fascinating. It was Nazareth that got to 36%, by the way. Yeah, really interesting, sort of like a group cultural change. But we'd be happy to come back and let you know. We're hoping that this is the winter where we break through actually you can have both of them same time, you're going to feel okay. And what's the nursing home doing to say, actually, if you need some time off, we'll still pay you. So we're in winter too. We're really hoping that it will be a breakthrough.
If I may just add to that, the answer to the question is you, Dr. Lang, and I'm speaking chair of the Health and Wellbeing Board now, and as the cabinet member, the answer is that you believe that we should be vaccinating the people who work in the homes as well. And if you will recall, Chair, this is the position that we took. We were unique in the whole of the country in taking this position early on in the pandemic, at a time when the Secretary of State later claimed he was putting a safe. Well, it's very important this. The government was claiming, and the Secretary of State claimed that he put a safe ring around care homes, and he wasn't. Hospitals were being told to discharge people into care homes. And I'm mentioning this because I think we have to carry on this conversation a little bit more clearly, making clear what we've learned and haven't learned from COVID. And it's quite clear, Dr. Lang, you did an exceptional thing. We closed our care homes until the NHS was able to find a way of discharging people safely. And you went in and you insisted from the very beginning that we test everybody who was asymptomatic as well as symptomatic, and that we also vaccinate everybody, as I recall it, or you test them. And I do think, Linda, I was just talking to Linda, and Lisa Redfern, I do recall Lisa Redfern telling me that people were she guaranteed £200 pay a day to people who were frightened about just what you said, getting ill and not being able to do the work. And I just asked Linda, and she tells me that nobody actually took that up, but it helped psychologically for people to do it. There is a lot of other learning from COVID, and I'm looking forward, as we get the answers to the next questions, and I'll have some of my own at the end, to understanding how far we actually have learned from COVID, because it's something we talk about and we talked a lot about previously. And I'm still unconvinced that we're taking the time to look at those very strong and helpful lessons when it comes to vaccination. Thank you.
Thank you very much, Councillor Coleman, for this very important reminder. And also, yes, what have we learned? And we do not want to repeat the same mistakes and what have we learned from that process, which is so important. Okay, in terms of the order I have here, I would now like to invite Meryl, please. Thanks for your patience.
Thank you, Chair. It's a bit hard to know how to pick up on this because so much is said, and yet in some ways, I sort of feel we're no further forward than we were last year, or the year before, or the year before. And I'm not sure how many years back we need to go, and I've just lost my screen. What I do want to say is that that one-page report from the borough did seem to show to me some learning that's taken place. It showed a borough that's willing to change its practices and go out and look at what might work. But I don't get that from the report that's come from the ICB. I get a terrible feeling of complacency, and when we hear we can only do what we can do, that seems to me a very defeatist approach, and one that worries me completely because we've failed. We've failed in Hammersmith and Fulham on vaccinations, and we've been failing in Hammersmith and Fulham on vaccinations for a very long time. The figures that were presented in the paper tonight on the total borough figures across the pretty one with yellow and green and pink and green arrows going up and red arrows going down is a dire picture. A dire picture for Hammersmith and Fulham. It's not the only borough where the picture is bad. In fact, if you look at what was the old tri-borough, you wonder what's gone on historically that makes the tri-borough so awful for vaccination, because it's been going on for a very long time. And I'm sorry if I'm talking a lot about this, but I think we need to recognise that history. And if you look, and I think it was page 103, I only printed off a couple of pages, at the percentage of vaccination uptake this year, I think it's under the flu, the seasonal vaccinations. Even this year, when we're supposedly having learnt from past years, Hammersmith and Fulham, across every age group, is significantly lower than North West London ICB. It's significantly lower than London, and it's certainly significantly lower than England. And yet we come with a paper tonight that talks in broad general terms. That's simply not good enough. And for years we have asked for specific plans for Hammersmith and Fulham. We need to know why the rates are lower for our borough. We need to know the specific analysis for this borough, not the generalities for North West London or for London. We need to know what's happening or not happening in Hammersmith and Fulham, because unless we know that, we can't do anything about it. And then we need to have a specific response or set of responses for this borough. We need a plan that's specific to Hammersmith and Fulham that says these are the populations that are not having the vaccination. These are the reasons why there are reasons for it. It doesn't just happen. And then the response needs to tie up with that, that's the only way you're going to raise those rates of taking vaccinations, whether they are seasonal vaccinations, whether they are the vaccinations for young children and babies. I'm sorry, I feel passionate about this, and I think those things need to be said. What we've heard tonight might be a very good global or Northwest London picture. It does nothing to take us forward for Hammersmith and Fulham.
For the points that you've raised and the requests, the specific requests that you've made. No, it's important. It's important and very relevant. Jim, please.
I must say first, being an elderly Irish gent, I've had my vaccines, etc. So that's the virtue part of it. But let's get back to grubber reality. Look, the real question was the first question, because the map here of Northwest London, of the boroughs, this was discussed more or less in this room or in the Old Town Hall with similar officials 3 years ago, 4 years ago. There were red faces and things haven't changed. The figures are more or less the same. What actually worries me is that what we've been presented here is a kind of interesting academic paper where you have collected an immense amount of data, but there's actually very little which you draw from it about how you move forward. And that's the key thing. I think so far, what I've got in terms of action plans, it was quite interesting what you said about going into schools. I worked in education, and I know if you want to change with children, you have to go in there frequently, because parents learn from their children, believe it or not, as well as from teachers. So you have to go in frequently with messages which are simple, comprehensible, and accurate. And you will not get everybody, but you actually do set a train rolling. And I think I'm pretty glad that that's happening there. That's quite important. It's important you go into care homes with people, on the whole, my own age there, but 35% might be better than before, but my goodness, it's a pretty poor figure, isn't it? It really is. I wouldn't boast about it. But what worries me is the fatalism, because this is what we've done. During COVID, this borough did very well when it took over itself and worked with the local NHS people, but the borough took the initiative and went out. What we got here is moving in. If they come to a doctor's surgery, but you know, they don't, because these days we're told to keep away for a rather good reason, actually. And that goes for most of it. You go in if you have to, otherwise you stay away. What's the point of having an infographic on a wall in a doctor's surgery when you want to be in fast, out fast, get to work or wherever? The real thing is going out. Look, there's a range of shopping centres here. I would say you need to be looking at the Northwest London work practices. People go to the King Street Mall, for example, where once a month the shopping centre allows for free the voluntary groupings which work in this borough to present their wares. They're seen there. You could go to tenants' halls in Clematney Estate or into White City. You would have to turn up regularly so people get to trust you, not just going in once, but going in frequently, and not just going in twice a year, but turning up with people with stuff written in English, because what we've got is like Google Translate this evening. It isn't quite English, but it's not another language either. But if you say that to most people, they would not know what you're talking about. So you need to get out there where people are. You need to know that people will pick up leaflets which are clearly designed, which give clear explanations, and which tell people where to go. But nobody knows. I know because I'm pretty old. I go and see my pharmacist. But it's a good map. I'll bet you most people don't know about these because nobody has told them. But when I go home tonight by bus, the bus would probably on the side have an open day for a sixth form school or college. If you walk past bus shelters, there will be notices there, some really good ones from NHS England about cancer and cardiacs, but there's no drive of that kind about immunisation. But immunisation saves more money. if you want to be grubby about it, than anything else going forward, unless you have that drive looking at our borough with KNC Westminster, because we're the three bottom ones here, you will not get take up. You'll have people doing what they've done over and over again. But Einstein explained what that meant. Let's not go into it. It was not it was not a praise, but it's the going out part. And I miss that in your plans here. It's for the system, for system professionals. It's written in professional language. I can follow it because my job demanded I do that. But most people will not see that they're being called in because they're being offered something which they might take advantage of. If a lot do, then more will follow thereafter. And the question was put about structural racism. That's not in the past. It continues. It's a continuing blight on this society. You have to engage with people from the Black communities, the various communities which feel under threat from the parts of the state to say, how do you design materials which they understand, which answers questions, and which says, we are not the state coming down on you, we're going to work with you. And I miss all of that here.
Thank you very much.
Can I just come back in? I mean, absolutely take on board all of those comments, but the outreach model that I've described is about taking the intervention into communities. It's about working with communities. It's not about GPs doing that. The outreach model we are proposing is a roving service, and we want to work with the communities that you've mentioned. As been mentioned by Nicola, there was a clinic running in the last day or so in Hammersmith and Fulham, and we want to build on that. It's about working in shopping centres and working in food banks and in other areas. Absolutely.
Thank you very much. Thank you. I've got Linda who I know wants to come in, please.
Kevin, nice to see you again. I just have to come back on that, Kevin. As director of COVID, we have learned nothing from COVID on that. We don't go out to communities on a 9 to 5. We go out in an evening and weekends. And the model, the roving model, is still based on an NHS business offer. It's not based on a community need. And that's the bit. And I'm sorry to harp on, because I equally as passionate, because I spent 2.5 years trying to sort it out with Nikki and yourself. So absolutely nothing has been learnt there. We've already got the models of community intervention. We spent 2.5 years building trust with our communities. Nobody from NHS England has come to us and asked us, what difference has that made? What messages have we got from the community? So don't start from scratch. And please, the one question I would say, you talked about investment in this and a lot of investment. How much is that investment? And what can that look like for Hammersmith and Fulham?
Well, I mean, the investment is what the current investment is. We have a funded roving team, which is funded through Access and Inequalities funding. And we're using, that resource to, we think, we want to build on what they've done to date. I take on board, all of those comments, Linda. But people, we're talking about a workforce that does operate. The roving team have operated at weekends previously. They have operated into the evening on occasion, and they've got a static site at CP House, which was operating at weekends and in the evenings as well. So, but absolutely, I'm not saying that this is completely resolved and resolved the issues, but we've got at least something to build on in terms of being able to say that the offer is not just through primary care, it's not just through GP practices, not just through community pharmacies, but there's that other bit, which is about outreach, which is about taking, the offer into communities and understanding what communities want from vaccinations and immunizations. I take your point about it not being a 9 to 5 offer, but we as I say, we have experience of doing clinics outside of the 9 to 5 operation.
Thank you, Kevin. Linda, you want to
just one more point? So I did hear you say there's been considerable investment. Are you saying there's no increase in investment in here?
Well, in terms of investment is a broad term. It's investment in terms of what the team are doing, in terms of building the workforce, in terms of, working with local authorities, working with our community groups, time investment, all of those things I've meant by investment, not just about financial investment. The financial investment we have at the moment is what the allocation we get through an access and inequalities funding allocation to support the work of the roving team. It's not broken down individually by borough. The roving team is a system-wide offer, but it's an offer that is shared across all boroughs, including in Hammersmith and Fulham.
Thank you. I would now like to invite Councillor Coleman, please.
Thank you. Yeah, I've already, thank you very much, Chair, and I really appreciate the opportunity to have this discussion and so many people from the NHS taking part in this meeting. Some of what I say is, I'm afraid, going to be a little bit repetitive, and some of it maybe I can ask some questions. This is the 6th year in a row in which the figures for Hammersmith and Fulham's flu vaccination particularly, are wholly unacceptable. 6 years ago, when I was chair of the Health and Wellbeing Board, I asked why this was. The answer given to me by one of our local NHS people is, oh, well, not everyone wants to get vaccinated. I've heard that again tonight. And I've heard that tonight, and I've looked at the figures for Kensington, Chelsea, and Hammersmith and Fulham, Westminster, which are all part of the tri-borough health system that still exists. And I've looked at the figures for London and for the West London. And I presume in the rest of London, West London, North West London, and in the rest of London, there are also people who don't want to get vaccinated. It's just there seem to be rather fewer of them. So I'm not interested in, and I don't think any of us here should be interested in talking generic things like not everyone wants to get vaccinated. I think what we need to be interested in is, as Meryl said, is what is going on in our borough. And for 6 years in a row, our figures are worse than anywhere. And that is a disgrace. And it's a disgrace because we haven't addressed it. And there's no evidence that we understand what we need to do to address it. I talk about learning from COVID. One of the biggest pieces of nonsense that came around as COVID, thank goodness, died down was that we would learn from COVID. It was, I mean, I'm a politician, but honestly, I bow to the National Health Service in their ability to use speak. And it's not you people here, but the nonsense that was spoken about learning from COVID. We are learning nothing from COVID, as Linda suggested. The very simple lesson that we learned from COVID is that if you take the vaccine to people, they are more likely to take it. It's not more complicated than that. We tried putting people in front of, we tried getting people who are of faith, vicars and priests and imams, to say it's safe to take. It didn't make a difference. It hardly made any difference. We put vaccine buses on estates. People queued up to take vaccines. I fought to get pharmacies accepted as a place for vaccination. I fought, and we got more because I fought for it, and that was fought on the as a suggestion from our public health and our social care teams. Because I fought, we got more pharmacies doing vaccinations than anywhere else in Northwest London. Now, that's not great for Hammersmith and Fulham. It's just a bit of a shame for everybody else. We had 10 pharmacies. Now we have a problem with children not getting immunized. Are they able to get immunized in pharmacies? They should be. If they're not, why not? How can we talk about investing in all the right things if we don't invest in the common sense approach of vaccinating, immunizing children in pharmacies? And if we talk generally about pharmacies, why in the poorest part of our borough, in College Park, where we also have high numbers of people, older people living, is there no pharmacy included? If you look at the map in your presentation, there isn't a pharmacy at the top of the borough that seems to be included, unless there's one over the border, which residents expect to go to. So we are where we were 6 years ago. We don't seem to have learnt from COVID. So may I ask you, can we at least do one thing, which is to give children the opportunity to be immunized in pharmacies?
Well, certainly I'll sort of respond to that, and then maybe others can come in. In terms of testing out vaccine in new spaces, utilising community pharmacies to offer vaccinations to children is something that is being considered at the moment. There are a number of things that need to go through. I don't want to get bogged down in the bureaucratic speak, but I mean, in terms of governance and making sure that delivery can happen in those spaces, there are a number of things that need to take place. But absolutely, vaccine in new spaces is something that is being considered at the moment. And in fact, we have that as part of our North West London Immunisation Board. We actually currently have that as an action for the board to look at potentially piloting community pharmacies to test out this approach.
Thank you, Kevin. Susan, I see you've got your hand raised. Do you want to come in?
Yeah, so I can maybe a couple of things, because I think it is, I think the comment is very well taken about, the learning from COVID and a lot of this. And I think there's also something, I mean, there was a lot of material in this paper, but what we did 10 years ago, 20 years ago, and even 6 years ago is, we have a lot more vaccines than we've ever given, and we're going to be introducing even new vaccines. RSV vaccine will be coming up, a chickenpox vaccine, and so the portfolio has actually grown quite substantially. In 2018, we had a measles outbreak across London where over probably 2,000 or 3,000 children were infected. So I think we're not suggesting we're in that place, but we're feeling very fortunate that we're not back in that outbreak terrain, but we're very worried about it. I don't think anybody considered that we might be reintroducing polio, that would be a threat to us here in the UK, but that has materialized. And so there's a number of different things which I think have changed over time. But I think certainly the childhood situation is one that we're very much concerned both about the gaps and the equity gaps, as well as the dropping coverage. And then the point about the community pharmacies I wanted to make is that it is, so we have introduced some booster dose into community pharmacies. The difficulty with community pharmacies is also that it's a business model. So we also have to have the supply of vaccines, and we have to have the people turn up. And so that's one, as Kevin said, is we're starting to pilot, but the pilots, the national pilot is taking place in Manchester. And I think there has been some, I don't know what the evidence is yet in terms of what the uptake has been for that, but it also relies upon those pharmacists, actually taking up the different vaccines and antigens. Nicola, I don't know if you or colleagues and also want to answer some of the questions about some of the local initiatives and the childhood side of things, or if...
I think it's heartening that Kevin said that we could try the pharmacies, because and Councillor Coleman's been a big proponent of that. We would be very keen to be a pilot site. I know that I had discussions with NHS England in 2022. We would like to be a forerunner in the pharmacy pilot, please. I had discussions with Ozar and Canary in Fulham, and they were all ready to go. I think we'd love to work with you on that. We don't want the sort of governance, data, pinnacle sonar to stand in our way. So if you're looking for pharmacy pilot sites, we've actually got a pharmacy that's ready and raring to go with 2 young pharmacists who would love to do it. So thank you.
So,
thank you very much, Councillor Coleman. Do you have... Okay, Linda.
So I think just to support what Nikki's just said, during COVID, we had lots of conversations with pharmacists, and they were very, very frustrated, let's say, about they know that they could do more if they were given the right support to do it. So I think the energy is there and the appetite to do it. They are a massive community resource, which is a fundamental part of primary care. And I think we've really got to spend more time actually talking to them, understanding what pharmacists need and why pharmacists can't do things as well as residents.
I'm wondering if we can agree, is it something that Dr. Lang and Linda, you would want to, for the purpose of the minutes, want to put forward as an action?
Let's discuss this with the NHS, if we may, Chair, because I think that's very helpful for you to pick up on that.
Okay.
Just the point about the doing a pilot. Can we do a pilot, Kevin?
As I say, we've got an action to for part of the immunisation board to look at pilots in North West London. We have to get agreement from our regional colleagues because they have the commissioning relationships with community pharmacies. But actually, you know, the principle in terms of testing out vaccine in these spaces is one that, you know, I would support, but we have to go through a number of
Oh, for goodness sake.
well, I mean, it's just that's the reality of it.
But, you know, you do have to, but you have to want to do it.
I do want to do it.
We had to do it in COVID. We were brilliant in COVID. We were all brilliant in COVID. We all look, very interesting figures. You mentioned measles in 2018, Susan. I've been looking at the data in your presentation. And if you look at the vaccination coverage in all sorts of areas in Hammersmith and Fulham, there was a jump in 17-18 in the coverage. It was tremendous. And I was saying to Linda, what on earth happened? And I'm guessing that there was a measles outbreak because we failed to vaccinate properly beforehand. And then we did a panic vaccination in 17-18. I'm just saying this is how do I interpret the figures? No one else is seeking to interpret the figures. I was saying to Linda, what can we look at what happened in 2017-18 to suddenly have got all these people vaccinated? Because there's a real spike in measles, mumps and rubella vaccination. And there's a spike in Hammersmith and Fulham in the 6-in-1 vaccine and the booster. Much bigger spike than in London and much bigger spike than in the other parts of London near us. So why is that? That's a question I would have thought, looking at the data that you present in your own report, you would be able to answer. Have you got an answer there? You've got your hand up. I can't see the name, forgive me.
Carla has.
Yes, thank you. I thought it was actually noted in the report. There was actually a change in the way our child health information systems are the commissioning of those. So we believe it's actually more of a kind of a data change than a real change.
Okay, well, that's very helpful.
It should be noted in the report. Apologies if it
I
isn't.
appreciate that. That's a really helpful clarification. So coming back to that, thank you for that. So coming back to the the idea of children being able to immunize in pharmacies, I think I heard, well, they're businesses. Well, they are businesses, pharmacies, and they've got every incentive to get as many people vaccinated as we can enable them to vaccinate. GPs are businesses as well, for like it or not, and this may change over time, but that's the situation. And we don't, if that is a reason for not using pharmacies, it doesn't appear a hugely persuasive one. So if I can come back to it, brilliant that you're going to be talking in North West London about using pharmacies to vaccinate children. Of course, there are complications, but my goodness, as I was starting to say, and then I interrupted myself, there were huge complications in COVID, and we found a way around it because it mattered. Now, we have very poor child immunization rates. We have for 6 years now the lowest flu vaccination rates in our part of the world, probably possibly in London. We have to take this very, very seriously. So may I ask if you would take away our request, formal request, to be a pilot for child immunizations in pharmacies, please?
I would definitely take an action to have further discussions with Nicola, which is in the previous pilot that was mentioned, was supported by myself. But I will definitely take an action away to have those further discussions with Nicola to work through how we could potentially look at a pilot in Hammersmith and Fulham.
Okay, good.
Thank you very much.
That's very helpful.
Councillor
I haven't quite finished.
We're approaching the guillotine.
Okay, I haven't quite finished, and I'll aware of that. The other thing is, the fact is, we aren't any longer persuaded that we are getting the focus that we need in Hammersmith and Fulham. The tri-borough figures are dire. Our figures are dire. We would like not to have to operate within an ICS. Well, obviously, I sit on the ICS board, so I'm very happy to operate in the ICS in general terms. But we would like our own coordinator, our own borough coordinator for vaccinations, just for Hammersmith and Fulham. Might that be possible?
Well, you have an immunisation coordinator working across the tri-borough.
No, I'm not talking about that. I'd like one for Hammersmith and Fulham. It's not working in the Tri-Borough, and I don't think it will work in the Tri-Borough. And I think we'd like one for Hammersmith and Fulham. We didn't operate in the Tri-Borough in the same way in COVID. We did things which nobody else has done in COVID, and we saved lives and we got people vaccinated. I'd like to apply. I'd like to learn from COVID. Maybe, I think we'd all theoretically like to learn COVID. I'd actually like to learn from COVID. Can we have our own borough coordinator, please, for Hammersmith and Fulham? That, for me, would be a very worthwhile investment.
I'm not able to promise that. I'm
So how do
afraid.
we take that forward as a formal request? I mean, I'm at the point of, I don't know what it is. When we don't do a housing repair properly, we have a stage 1 complaint. When we don't respond to a housing repair properly on a stage 1 complaint, it goes to a stage 2, and it ends up with a local government ombudsman as a council if we don't get it right. What is the equivalent of a stage 1 complaint? 6 years of no real improvement in our vaccination figures in Hammersmith and Fulham. How do we as a borough, and you can tell, I'm sorry, I'm not hiding my frustration at all. Well, where do I make a complaint to? I presume it's to you. We don't think that you're doing the best by us that can be done. And I'm worried we're going to get swamped in the Tri-Borough, continue to be swamped in the Tri-Borough, and then swamped in the ICS, which as I say, I sit on the board of. We would like our own focus in Hammersmith and Fulham, give us the chance with our own borough coordinator and doing unique things to improve our vaccination rates from old to young.
Thank you, Councillor Coleman. I'm sorry, we are approaching the guillotine, and I know I appreciate the importance of asking these questions and hopefully getting a commitment from Kevin that some of the actions that we're requesting will be considered.
I wouldn't. I'm sorry, Chair. Forgive me. We can always extend the meeting by 5 minutes. I think this is, and even if people want to go and have dinner, this is probably
absolutely.
This is possibly. We reached, everyone has asked a lot of questions and taken a lot of time in doing that. Yes. And I think that we need now to actually get to the nub of it. And sadly, we're getting to the nub of it at 7 minutes to 10.
Can we agree collectively an extension until 10:15, please?
No.
Well, then you don't have to stay. But okay. Well, I'll tell you what we'll do. I'm very happy to leave it here and take it forward at the Health and Wellbeing Board if that's necessary.
No, let's extend until 10:15. It's only
I'm not going to be able to stay on beyond 10 o'clock. I'm sorry. I'm not going to be able to do that.
I'm only asking.
Please, let's make the most of the time that we've got left. There are a few questions that we have been asked to consider. Please bear with me. So I know Councillor Absorb, you've got a question, and I know Lucinda also has got a question, and I would also like to ask a question. But if you please bear with me. And also, I would appreciate some cooperation from the members of the committee, just an extension of a few minutes. This is an important topic, and we're talking about the last children.
Important, but it is worth talking.
Okay.
So,
Sir, I'll ask you after.
I'm happy to withdraw my question so the question can be answered.
Thank you. That's a very helpful thing. I appreciate that, Councillor Apthorpe. So, Kevin, can we come back to this? Councillor Apthorpe's not asking her question, so we have a couple more minutes before the 10 o'clock guillotine falls. We don't have much confidence in what's going on. And you're great people. It's not about you as individuals. We just don't have great confidence that the issues are being addressed in the way which we think they need to be addressed, because 6 years now we have the lowest figures and our children aren't getting vaccinated appropriately either. So we would like a chance to do something different here, see if we can come up with it. We'd like our own vaccine immunizations coordinator, and we'd like to try out pharmacies to immunize children. Now, if we don't get that, we'll be here. I'm sure we'll be here in the 7th year in a row with poor figures. Give us a chance to do something.
Yeah,
what the obstacle is, what I need to do as the deputy leader of the council, and the chair of the Health and Wellbeing Board, and the member of the ICS board, what I need to do to get the NHS to take this seriously. The request that we're making.
Can we please have an answer to that question, please?
So it's in 2 parts. So the first part, I've already taken an action to have a conversation with Nicola to look at the opportunities of Hammersmith and Fulham hosting a pilot, a community pharmacy pilot. I've taken an action to have those discussions. The second part is I'm not in a position to promise financial to make a financial commitment to have a borough-based immunisation coordinator. However, that doesn't stop Hammersmith and Fulham having conversations locally on whether there are other funding mechanisms locally to support the idea of having a borough-based immunisation coordinator. The current immunisation coordinators who work across all of the boroughs, we have 3 of them working across 8 boroughs in northwest London, are funded through NHS England. But there may be opportunities locally that you can explore in terms of a funding model that will enable you to have a borough-based immunisation coordinator.
In terms of funding models, I do have a question. Can there be a relocation of the quality and outcomes framework funding for that is not being paid for to underperforming GP practices, so that the school-age immunization service can provide that immunization? Can you relocate funds to a different team?
Not from the school-aged immunisation service provider. I mean, that's a commissioning arrangement the regional team have with the SACE providers. But I'm saying there may be other options locally that could be explored. I certainly am not in a position to answer the question directly. I'm not in a position to make a financial commitment to Hammersmith and Fulham that would allow you to have a borough-based immunisation coordinator. I simply don't have the access to those funds to be able to commit to that. But I'm saying that there may be options locally that could be considered.
I want to go back to Dr. Lang. Do you think in terms of what we're discussing and funding allocations, is there a different model that we could consider?
I think we'll take that away and discuss with Linda and Councillor Coleman. We'll do that.
Okay, thank you very much. I would also like to make a suggestion. Can we possibly consider a working group to focus on this topic?
Yes.
Well,
what specifically?
Oh, there's the vaccinations.
I just wondered, just for clarity of the figures, would it be possible to have figures going back 5 years so that we can see whether there's been any progression in which boroughs where it's gone up and down? Because I know the arrows are going up and down, but we don't know what they were going down or up from.
Yes.
Thank you.
Can this be produced, please?
Yeah, I'll leave that one to Carla because I think that is possible. Yeah, we've got data going. Carla, do you want to come in?
Yes, sure. And you actually see in your report the graphs that you're presented with go all the way back to 2013-14. So yes, absolutely, we can. There are some in your report as well.
Thank you very much. I'm mindful that we're close to 10 o'clock. I wanted to know, just to confirm, what are the actions that have been agreed so far, please? Kevin.
Yeah.
So I've taken an action to speak offline with Nicola to look at the option of a pilot, community pharmacy pilot in Hammersmith and Fulham. Very happy to do that. I think that was one of the key actions for me. Oh, and we were going to provide you with the data.
Children, if I may, you mean for children?
Children, yeah.
Cheers.
Okay, children, okay. I mean, I think you've listened from the different members of the committee how we feel that there's not enough focus in Hammersmith and Fulham. So please bear this in mind. Yes.
Chair, I think there's a real problem here because the action that's being taken away by the NHS takes no account of the fact that so many speakers here actually talked about the fact that there is no action plan that focuses on Hammersmith and Fulham. And there is a real need for the NHS to come up with an action plan that focuses on Hammersmith and Fulham, hopefully one that's drawn up, perhaps with Nikki, but certainly with the borough more generally.
Thank you very much. I see, Susan, you've got your hand up?
I was just going to refer to the Hammersmith and Fulham immunization plan, which I think Tahara and Nicola have worked up. And so we're very keen to align. And so again, the DPHs are represented on the flu boards and on the Northwest London IMS board. and through the ADPH London IMS board, but we'd be very keen to work more closely with the Hammersmith and Fulham immunization strategy to see how we can improve based on that.
Yeah, just to say, Chair, we have a plan, a local one that we've created. We can share it.
Okay, great. Thank you very much. Yes, Linda?
I think, Chair, you were talking about having a subgroup of this PAC to be a working group to look at that plan and the improvement plans that are coming out, and who is doing what from NHSE, ICB and locally as well. I think that was your recommendation.
Yes, absolutely. Yes, that was a recommendation. So in terms of suggestion, how many, who would like to be part of that subgroup, please? Can we have that conversation afterwards? Okay. Okay, so this is another agreed action. Great. Okay. So anything else that we're missing?
I just had one very small question, which was, I just had a quick Google of the roving team, and there doesn't seem to be a contact. If you're an organisation who would like them to come to you, there's kind of no clear information accessible online for how that's possible. And obviously, as a local authority, we have a lot of contacts for people who there's already the trust with, and you could have access with. Is that possible? Is that something we'd be able to share?
It's not public. It's not public facing. I mean, the member of the public would not be able to request the roving team. It would come through our system partners, our community groups that we work with. There is a process, there's a pathway in place, a referral form that can be used to request the support of the roving team, but it isn't obviously offered to individual patients. We do vaccinate individual patients through a request for the roving team.
I wasn't suggesting individual patients, but thank you.
Yeah, so we've got a pathway in place. All local authorities use the roving team and understand the referral process, and as do GPs and other system partners.
Okay, thank you very much. It's past 10 o'clock. I want to thank Susan, Carla, Kevin, Lucy, and Anne for your time this evening. I really hope that you can take on board some of the serious concerns that we have at local level. We're here to scrutinize, and we are not very happy with what's happening, and we do not want to repeat the same mistakes from previous years. So please take into account what our requests are, and we look forward to receiving an update on the actions agreed. Thank you. Okay, colleagues, we've got two more quick agenda items. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you very much. The next agenda item is the work program. So I suggest that we have a internal conversation in terms of the next agenda items.
Yeah, I thought we'd agreed to actually put after each pack to actually have a list of items that could sort of come up, and that we pick them at the end of each meeting, which is what we've done previously, and it worked very, very well.
Thank you. So can we have some support from you, David, in terms of circulating the list with the suggested items? Great.
Yeah.
Are we happy with that?
Yeah.
Yes, great. Thank you.
It'll make it just easier for everybody.
Yes. And then the next agenda item, dates of future meetings. The next one is the 31st of January, 2024. So as we will not be meeting in between, I wish you all a good end of year. And if you're celebrating Christmas, Merry Christmas.
Merry Christmas, everybody.